name is Hubert Wong. I will be your host tonight through our fun and exciting evening. I'm a pediatric nephrologist and a consulting pediatrician with the Scarborough Health Network, and I've been with the hospital for the past 15 years. A great agenda tonight. We have a host of great speakers. I would like to personally say how excited I am about this conference. We have had a long history of regional pediatric educational conferences in Scarborough. And despite the hiccup of the COVID pandemic, we still have over 7 international and national speakers tonight and over 250 registered participants. This conference will clearly be a resounding success. Before we begin, I would like to mention some of the rules we have tonight. First, all the participants that have joined will be muted. There will be a variety of online polling and interaction throughout the evening, and we ask that you respond through your devices. If you have any questions, we ask that you include them in the chat in the Zoom feature. Due to time constraints, we will not be able to answer all the questions online tonight. But if you have lingering questions that you would like answered, then we would be certainly happy to connect you with the participants and the speakers afterwards. Thank you once again for all attending. I would like to first introduce our opening speaker. Glenn Boatswain is our Vice President and Chief Nursing and Allied Professional Executive at the Scarborough Health Network. And within her portfolio, she oversees the following, which includes the Women's and Children's Program, the Pharmacy Services, the Interprofessional Practice and Allied Health, and the Quality Patient Safety and Patient Experience. It's really quite an amazing talent. Thank you, Glenn. Thank you, Glenn, for joining us today, and we're happy to have you here.
Thank you, Dr. Wong. Good evening. It is my great pleasure to welcome you to the virtual Paediatric Pearls Conference for 2021 in collaboration with the University of Toronto. I would like to sincerely thank Dr. Hamid, Dr. Wong, and the planning team to still be able to hold this conference despite all of the work and challenges of the pandemic. Today's event just would not have been possible without the organizers and esteemed panel assembled here today. So thank you. Here at Scarborough Health Network, when conducting our clinical services plan or our health human resource planning, the goal is always to look at what our community needs are for now and over the next 10 years. And it is with this strategy in mind that has enabled us to recruit the talent and expertise that is needed to deliver services in Scarborough. In reviewing the agenda and presenters for this evening, I know that the attendees are in for an informative session on the impact of COVID-19, isolation, virtual learning on our youths and pediatric patients, and the effectiveness of vaccinating our youths. As we are planning for COVID-19 vaccination for children between the ages of 5 and 11, the expert advice and panel discussion this evening will also be beneficial when counseling your patients and parents as they prepare to get their younger children vaccinated. Here at Scarborough Health Network, we are proud and very humble with all of the work that we have undertaken with our primary care physicians, our academic and community partners, to be able to fully vaccinate over 84% of Scarborough residents with COVID-19 vaccination over the past little while. Thank you to the nurses, the physicians, allied health staff. Thank you for being flexible and nimble in an ever-changing environment to be able to continue to meet the needs of our diverse Scarborough community. Sincerely thank each and every one of you and looking forward to a very informative and enjoyable evening. Thank you so very much.
That was wonderful, Glenn. Thank you very much. Glenn has been a wonderful resource and longstanding supporter of the Women's and Children's Program here in the Scarborough Health Network. We are always glad to have you here with us. Next, I would like to introduce our lead event organizer, Dr. Mohammed Hamid, who, as director of the Paediatric Pearls Conference from before and after the COVID pandemic, has really advanced the program beyond a regional subspecialized service. With the successful and continued production of our online attendance Dr. Hamid will likely lead us to a provincial and national stage. Thank you, Dr. Hamid, and all of you, please help me in welcoming and thanking him for having such a successful conference tonight.
Thank you, Hubert, for a generous introduction. Hello and welcome everyone to our third annual Paediatric Pearls Conference 2021. We are happy to have you, so many people with us today. I'm glad to say that more than 250 participants has registered with us. And as you all know, and rightly Glenn said, due to this challenging time of pandemic, we are still able to provide our Scarborough Health community and our other healthcare professional a learning opportunity through this conference. We are unable to hold a conference last year because it's the beginning of the COVID and we could not stage the conference. But on this conference, we have many interesting presenters and experts, especially our amazing and wonderful SHN physicians. I can name all of them, but with the time of shortage of time, I just say welcome all of them, including our keynote speaker from United Kingdom. He is representing University of Huddersfield, UK. On behalf of our Paediatric Pearls Conference team, I hope you enjoy our event and thank you all for joining today.
Thank you, Hamid. That was wonderful. So I'll begin with our first speaker, and I'll do a little introduction before she begins. So Dr. Andrea Young is a comprehensive practicing pediatric ophthalmologist. Dr. Lung received her medical degree from Queen's University and completed her ophthalmology residency at the University of Toronto. She then went on to fellowship training in pediatric ophthalmology and strabismus at the Children's National Medical Center in Washington, DC. Besides her commitment to her patients, Dr. Lung is dedicated to providing eye care to adults and children in the developing countries and places such as the Bahamas, the Dominican Republic, Swaziland, and other places. Thank you once again, Dr. Lung, for visiting us and speaking with us tonight.
Thank you very much for the very kind introduction, Dr. Wong, and thank you, Dr. Hamid and the planning committee for inviting me to speak at this year's Paediatric Pearls Conference. And good afternoon or good evening to everybody who's here attending. My talk is titled A Bird's Eye View of Pediatric Ophthalmology, Everyday Diagnoses and New Treatments. I have no conflicts to disclose. So our objectives this evening will be to discuss the diagnosis and treatment of a frequent presentation of a red eye in primary care settings, to discuss vision screening in children, and also to review some emerging treatments in terms of slowing the rate of progression of myopia in pediatric patients. So the first thing that we'll start with is an audience poll. So blepharitis does not impact visual development, true or false? It's a pretty close call here. All right, so 56% of the audience attendees feel that it is true. So actually, blepharitis can impact visual development in children, and we'll see in the following slides how this comes about. So the red eye, this is probably one of the more frequent presentations in a primary care setting, and can be a bit of a challenge to diagnose, especially with limited resources in an office setting. But quite frequently, you can make a diagnosis or at least narrow it down based on history and a very brief physical exam. Quite frequently, patients will come in with viral conjunctivitis, and the typical history is that of a red eye, sometimes unilateral or bilateral, tearing, foreign body sensation, a lack of discharge, and a preauricular lymph node if you're doing an examination. In some severe cases, the kids will have lid edema that can be confused with cellulitis. And even in very severe cases, a symblepharon, where the bulbar conjunctiva and palpebral conjunctiva can become fused due to the inflammation response. And that's that top picture there. The treatment for viral conjunctivitis is really conservative. So cold compresses, artificial tears, a lot of education. So I really tell parents there is no role for antibiotics in these situations. I do warn families that it will spread to the second eye if it hasn't already, usually within 3 to 5 days. I emphasize hand hygiene for families as well as infection control, just because quite frequently patients will come in with parents who also have a red eye. I warn families that it's typically worse in the first week, but can actually last up to 4 weeks depending on the strain of the virus. And I do watch for something called subepithelial infiltrates, which are basically immune complex deposition in the cornea that can develop 2 to 8 weeks after the presentation of conjunctivitis. And patients with this will present with photophobia or blurred vision after their conjunctivitis is cleared up. And you can see this in the bottom right photograph. The treatment for this is either observation if it is not severe, or sometimes a long course of steroids if it's severe. Bacterial conjunctivitis typically presents with yellow-green discharge, and really the treatment here would be a topical antibiotic, typically tobramycin for a week. In patients where they might have risk factors for more severe disease, such as a contact lens wearer, I might put them on moxifloxacin for a week, just for Pseudomonas coverage. Allergic conjunctivitis typically present seasonally, of course, with presentation of itchy eyes, tearing. And if you flip the eyelid, either upper or lower eyelid, you may see this cobblestone appearance like this photograph on the right. And these are follicles under the upper or lower eyelid. The treatment again is conservative, so removing the allergens, cold compresses, and artificial tears. I typically find that if they have severe allergic conjunctivitis and they require some treatment, I tend to turn to olopatadine 0.2% once a day, just because of the daily dosing. And I find that compliance is a lot better with lower daily dosing rather than ones that require 2 or 3 times daily dosing. I tell families that they should expect a 2 to 3 month course of the eye drops and not to stop the drops even if the child is feeling better. And I do warn them that if this is a seasonal issue, they should start about 2 weeks prior to allergy season to make sure that the best efficacy is, or the child is actually treated prior to allergy season. I avoid vasoconstrictors, so these are typically over-the-counter treatments like nifazolin, which can cause rebound hyperemia. So other types of red eyes. This is actually something that I see quite frequently and is not always easy to diagnose. So blepharokeratoconjunctivitis is due to severe blepharitis, and severe blepharitis, which is a chronic inflammation of the meibomian glands, can cause keratopathy, conjunctivitis, and corneal neovascularization in severe cases. These children usually present with recurrent styes or recurrent eye or lid redness, irritation, maybe some photosensitivity, and tearing. And on examination, they can look like children who have HSV keratitis. And you can see why in the photo below. So down at the bottom left, you can see this child with a chalazion on her upper eyelid. There's a little bit of lid crusting and mild lid redness and some mild conjunctivitis. But if you look closely at the cornea on the bottom right, you'll see that there's some new corneal vessels leading up to an area of opacity just next to the pupil. And in these situations with the corneal neovascularization, the corneal scarring that can result even with treatment of the neovascularization can lead to amblyopia and a reduction in vision, sometimes permanently for some of these children. So treatment of this is really key. And the treatment of blepharokeratoconjunctivitis as well as blepharitis and chalazia are quite similar. The key is really education. So I do emphasize to families that this is a chronic issue, and I do emphasize the long course of the treatments that are going to be required. I do find that compliance usually tends to fade, and it's really quite difficult to try to keep up the treatments, but really with some education, I do find that the families start to understand, and then the treatment and outcome is a lot better. I encourage hot compresses, 5 to 10 minutes, 4 times a day. It sounds like a lot, but I do tell families to just bunch it all in the evening when they have time. Daily lid scrubs with baby shampoo is helpful as well. In cases where there are chalazion that are persistent despite aggressive treatment, hot compresses and the like after 2 months, some are eligible for an incision and curettage under a general anesthetic, but many of the chalazion actually resolve with conservative treatment. For antibiotics, I tell families antibiotics alone are not the solution. I will sometimes add erythromycin ointment 3 times a day to the lids for 1 month, in addition to the hot compresses and the lid scrubs. And in severe cases such as recurrent disease or patients with corneal disease, I will actually put the children on azithromycin weekly for 6 weeks. It is an off-label use of azithromycin, but it can actually help kind of dry up the meibomian glands a bit and actually help with some of their inflammatory responses. Topical steroids are very helpful, but obviously need to be monitored carefully. And some patients will actually even need a topical immunosuppressant like cyclosporin 0.05%. So red flags for red eyes. So who should we refer? So patients with significant photophobia, so ruling out iritis or pediatric glaucoma. Obviously, if a patient has ophthalmos like this child on the right, they should definitely be seen urgently. Any patient with a history of contact lens wear in a red eye should be assessed. Conjunctivitis in a patient under 1 month of age, especially if there's a lot of discharge, should be assessed for gonococcal conjunctivitis. Recent eye surgery, and any patient with a history of HSV keratitis should be assessed. Of course, sometimes things are not always clear with children. There may be a history of trauma for some children, but sometimes a very unclear history might be a cause for concern as well. This patient at the bottom right has a globe rupture. You can see a knuckle of iris protruding from the limbus there and a peaked pupil. But sometimes it's not this obvious. And I do recommend if there is this history of trauma, being very careful, and you can lift the lid. And I have had some patients with globe ruptures where the rupture is actually hiding underneath the lid. So a quick examination could help diagnose that. So vision screening in children. Normal visual development starts with a blink to light reflex, which is the most basic response. It's present in premature infants. It's present even when children are sleeping, actually. Fixing and following on faces and objects starts at around 1 to 2 months, but may not develop until about 3 to 4, depending on the child. Any child that's got poor visual attention or strabismus after 3 to 4 months should be referred for further assessment. Vision starts off at around 2200 at the first few months of life, improving all the way up to 20/20 by age 5. The American Academy of Ophthalmology and the American Association of Pediatric Ophthalmology and Strabismus have certain recommendations for pediatric eye screening. So for newborns, they should have symmetric red reflexes. And then between 1 month and 4 years of age, they do suggest that an ocular assessment be done for every child during the well-child visit. So looking for strabismus, eye movements, and the red reflex. After age 3.5 or so, visual acuity can be done every 1 to 2 years, either in the office or at the optometrist's office. The Canadian Ophthalmological Society put out some recommendations in 2019, recommending a complete ocular examination, including a dilated refraction and a motility assessment by the optometrist or an ophthalmologist, ideally by age 3 years. And this is really to pick up patients who may have undiagnosed amblyopia. Now, working with residents and medical students, I think many people find that the red reflex exam can be quite challenging, especially in infants, babies with dark eyes. And so these are some of my tips, which I found quite helpful. So the first is actually to turn off the lights. With dim lighting, hopefully the pupil dilates a little bit further, and so you can see a little bit better. Having the parent hold the baby upright will help keep the baby's eyes open. I have residents or medical students hold their ophthalmoscope up to their eye and then move back until the entire circle of light falls on the child's face. And that way they can simultaneously view both pupils at the same time and compare both red reflexes at the same time. So there are patients who obviously will need a referral to an ophthalmologist. For example, those with an abnormal red reflex or nystagmus, strabismus, poor fixation. But I would actually consider patients who have a family history of conditions such as retinoblastoma, pediatric cataracts or glaucoma, retinal dystrophies and degeneration. Some family history of amblyopia or strabismus can be concerning as well. And if there are twins, and if one twin is referred, I do usually recommend a screening assessment for the second twin if there is pathology found. In terms of referrals to optometry, those would be patients who have a visual acuity of 20/40 or worse after age 3 to 4 years, or 20/30 or worse after age 5 years. And so myopia, this is a big hot topic, especially with the COVID pandemic. So the next audience poll question is this. Which of the following does not slow the rate of myopia progression? Atropine eye drops, wearing glasses with a lower power than necessary, peripheral defocused contact lenses, or taking breaks from electronic screens? That's great. All right, so actually, wearing an undercorrected prescription actually does not slow the rate of progression of myopia. And we'll discuss this in the following slides. So myopia is a hot topic, especially during COVID, now that all kids are kind of cooped up and staring at screens for the last couple of years. And this is an area that typically is handled by pediatric optometrists or even regular optometrists. But as a pediatric ophthalmologist, we do handle some cases dealing with myopia. And I thought it was a very important topic to bring up, as I'm sure you're getting many questions about different treatment options with your patients in your practice. So emmetropization usually occurs by age 6 to 8 years, and this is usually based on visual inputs that guide the growth of the eye. The prevalence of myopia varies depending on countries, with a high prevalence in East Asia, where a lot of these studies that I'm going to talk about have been performed. Risk factors include genetics as well as prematurity. And there are other associations as well, including environmental or social factors such as higher education, near work, IQ, affluence, as well as systemic diseases like Marfan syndrome or Stickler syndrome, and ocular situations or ocular conditions such as coloretinal coloboma, glaucoma, or lens subluxation. We do know that a younger age of myopia onset usually equals faster progression and a higher eventual myopic refraction. So
Andrea, maybe just wrap it up in the last minute, please.
Oh, sure, yeah. So there are many ways to slow down the myopic progression. So we do not undercorrect myopia. Progressive ad lenses like bifocals do not produce a clinically significant reduction. Low-dose atropine does help actually, and has been quite efficacious. And peripheral defocus lenses, which are either contact lenses or spectacle lenses, are quite effective as well. So these are my takeaways. There's no one effective permanent solution, but taking breaks from near work help, outdoor playtime helps, wearing glasses full-time help, as well as the treatments I had discussed before, the peripheral defocus contact lenses, atropine, and then ongoing monitoring.
Thank you very much, Andrea. Oh, sorry, you finished.
Oh, no, sorry.
Well, thank you very much. I think that was an amazing talk from Andrea Lung, who is our pediatric ophthalmologist available to us at the Scarborough Health Network. So I wanted to open up the discussion now to questions from the participants. If you have questions, please feel free to write them in the chat, and we will try to read out as many as we can. Andrea, maybe I'll start off some of the questioning tonight. My main question is, I'm sure that many people have who are participating in tonight, is that I often find myself in a situation where a child I believe or may believe has a possible pediatric emergency. Where's the best place for that child to be assessed? Because sometimes I'll see those children in our emergency department and they'll ask to be referred or transferred over to an office. So in your situation, what would you recommend?
So I think it depends on the situation, of course. So obviously, if it's anything like a trauma or something that might need urgent surgical attention, then either calling the ophthalmologist on call. Obviously, there's an ophthalmologist on call here in Scarborough. But if you're really worried about a pediatric specific issue, like a floor fracture, for example, even speaking to the resident on call at Sick Kids would be appropriate. For globe ruptures, pediatric globe rupture, for example, any ophthalmologist should be able to fix that. It does not need to go to a pediatric center per se. However, for example, here in Scarborough, we do need to do all of our microscope cases at the Birchmount site. So, speaking to the ophthalmologist on call may actually help guide you in terms of the referral process, in terms of seeing who is the most appropriate provider for that patient. So speaking to the ophthalmologist on call, if it's really urgent. If it's something that's, can wait a few days or, may not be imminently urgent, definitely sending a referral to your local pediatric ophthalmology provider is definitely helpful. And then following up with either an email or a phone call, depending on your relationship with that person, is definitely helpful. Just to flag that referral, as you know, we don't always go through our faxes immediately. So making sure that we are aware of an urgent referral is helpful.
So if I may ask a question, Andrea,
Sure.
What is the youngest age for the refractive surgery? This question asked by one of our participants, Anu.
Mm-hmm. So it depends on the situation. So I know that Sick Kids actually provides refractive surgery for children with developmental delays or behavioral issues who have a high refractive error but will not wear glasses. So that's actually a very great resource because it costs the patient nothing. And it actually has a big impact on their visual development because, some of these patients may be in wheelchairs and the glasses won't stay on them, or they may have behavioral issues where they've got a huge refractive error that's definitely causing amblyopia, but they won't wear their glasses. So Sick Kids will do refractive surgery on children. But it's case dependent. In terms of a healthy person, a healthy child who is considering refractive surgery just to get out of contact lenses or glasses, usually we tell families to wait until adulthood, just because refraction can continue to change throughout childhood. So I think most refractive centers won't consider a patient for surgery until they're at least 18 and their refraction is stable. And of course, they have to have enough tissue to have surgery and so forth. So they do need an assessment beforehand.
Thank you very much, Andrea. We're getting another question from Anne. She's asking you to describe a lid scrub. I don't know.
Sure, yes. So there's different things that are on the market. So if you actually go to the drugstore, there are little towelettes available at the drugstore that are disposable, and I think Lid Care is one brand, Sustain is one brand. I don't work for any of these companies, but they exist. And they're just a mildly soapy solution that's in a disposable cloth. The patients just open the packet, they close their eyes and just rub along the lash line just gently and then rinse off with water. Another way to do it is to use a quarter baby shampoo and 3/4 water. So it's a no tears, mildly soapy solution. Using a face cloth, just doing the same thing, rubbing along the lash line. I don't tell parents to try to keep their kids' eyes open. I just say closed lids and just rubbing along the lash line and then rinsing off.
Thank you very much. There was another question about the assessments over at the Birchmount Hospital, where I believe the equipment is. They're just asking about the process because our understanding is that operations in children is not allowed at the Birchmount right now. So is it possible for you to see these children over there, and do they require sedation sometimes, and how is that organized now?
So again, I think it's almost a case-by-case basis. Most children can be assessed as an outpatient, so done at, for example, the on-call physician's office. If they are an emergency and it's a patient that has a globe rupture, for example, my understanding is that they can be transferred to the Birchmount for surgery, and then I believe they're supposed to be transferred out. It depends on the timing of the surgery, right? So if it's day surgery, so if it's daytime, the surgery may actually be able to proceed, and then I think the child might be able to recover and go home the same day. They may not need to stay overnight, actually, even with a globe rupture. But again, nighttime cases may be a little bit more challenging. I do general anesthetic surgery at the Birchmount in the eye center, actually. So we do have capabilities to do general anesthetic cases with access to a microscope at the Birchmount site. But I have yet to do pediatric globe rupture at the Birchmount. So I think I know it's a little bit of a gray zone, but I've been told that we should be able to do these cases at the Birchmount.
Yeah, thank you very much.
So, do you have time? I have one question from Andrea.
There's enough time. Yeah, there's still time.
Andrea, I was just wondering about this congenital cataract in babies, although it's very rarity. Do the Scarborough Health Network, or you do the surgeries here, or it has to go to the sick kids?
So those would definitely need to go to sick kids. And the reason for that is multifactorial. These children need to be put to sleep, and then often an EUA has to be done. So we actually, when we do these cases at sick kids, there's a lot of diagnostic testing that's done while the baby is asleep, and then the cataract surgery is performed. So all the machinery that they have downtown is state of the art and really what is necessary. So we don't have that here in Scarborough. So we wouldn't be able to do a pediatric cataract here in Scarborough on an infant. Now, if it was an older child, again, case by case, right? So if it's an older child who might be able to be done under a sedation like an adult, maybe a teenager, for example, that could be done at the Birchmount, but again, case by case.
Maybe one last question. I think we have time. In the event that we do not get a positive red reflex, like in an infant during our assessment, what is the best approach to proceed with that? Are we referring those directly to you, or are we speaking to the ophthalmologist down at sick kids?
Oh, so red reflex examinations can be done within the next 24 to 48 hours, even 72 hours. It has to be done soon, but not emergently. So definitely an outpatient referral as an marked urgent would be the most appropriate thing to do. You do not need to send that down to sick kids.
Okay.
You sent to me.
Thank you.
Or your local pediatric ophthalmologist.
Sure. Thank you very much. I think that's all of our questions for now. So we're going to move on. Thank you very much, Andrea. I think all of us are very grateful for you coming today, and we appreciate you giving us this opportunity to learn. So I'm going to move on to our next speaker. Dr. Dipali Mankad is a developmental neurobiologist. She completed her pediatrics at Jaslock Hospital in Mumbai and pursued a diploma in child development from Trivandrum, Kerala. She completed her fellowship in developmental pediatrics at the Hospital for Sick Children and then a postdoctorate in autism. She has participated in multiple clinical drug trials and has also published numerous articles and authored a book chapter in the field of autism. She now works as an assistant professor at the University of Toronto and has joined the Scarborough Health Network as a developmental pediatrician. She works with a multidisciplinary team, and in the time she has been with us, she has already established a variety of programs, including the under 6-year assessment program, the school age assessment program, and the fetal alcohol syndrome disorder clinic. She's now working to establish a feeding disorder clinic in the future. We are very grateful for having her here with us. Thank you very much, all of us. Please welcome Dr. Mankad.
Thank you. Thank you so much, Dr. Wong, for such a elaborate and wonderful introduction. I have many in this audience, but the first person I would like to thank is Glenn for giving me the opportunity and a platform to work and do something for the community. So thank you so much. Without taking anybody's time, I want to jump into our topic today. I decided to present something which is different from autism and also COVID. I think we've had so much information on both these topics over years. I said, let's dive into something which is more common, a day-to-day topic, something that a pediatrician, a primary caregiver will stumble into their day-to-day practice so often. I want to talk about behaviors in school-age children. And I really want to say it's not a one-team thing. It's together we can do it. And no one person is more important than the other. No disclosures. So the main objective is to just give you some information about challenging behaviors, but at the same time, I want to focus on some solution-based strategies and treatment approach. Often developmental mental health assessments are so long, and I want to end the talk by giving some practical tips to a pediatrician or primary caregiver. Hopefully they can use this in their busy practice. No specific definition. I like to leave it as any behavior that disrupts the classroom or home. And there's so many different behaviors that may not matter to one family, but they may be very important to others. Some parents are okay if their kids go out, you know, they wet their hands, they dirty their hands in mud and come inside. And some parents are very particular about hand washing. And I feel all the families that we see deserve equal respect, and our job here is to help them troubleshoot those behaviors that they would like to change. I have a case which is something that I've completely made up just because I wanted to discuss and represent or really come up with all these behaviors that are by themselves so subtle. They're so very not important if we do not take the whole picture together. And very common in a younger age group, especially in those kids who are transitioning into a junior kindergarten program from maybe a nursery school or even from home setting, which often happens in many families living in our community. So there were very subtle difficulties noted by the family as well as the teachers. This child would be very upset in the morning. He would avoid school, be completely disorganized in spite of having, you know, full developmental, all the developmental skills of self-help. He was avoiding all kind of organization required to go to school. He had difficulty separating from his parents. In the class, he would be quiet. He wasn't the kid who was aggressive, throwing, biting, hitting, talking. And these are generally the kids who get most attention in the classroom. The teachers and everybody, they are affected more so by children who are externalizing and behaving aggressively. But this child was very quiet. He would sometimes just walk around. Sometimes he would just go under the table. And one thing the teachers had noted that he did not like bright light. Eating was on and off. Sometimes he would have big portions and sometimes he would just go hungry. Difficulty completing tasks. He would not like circle times. He was avoiding recess. He would play very quietly if he went to the playground. But what was very interesting was as soon as he went home and his parents picked him up, he had explosive, aggressive behaviors at home. Now, there was so much, and if someone does not come up with all these details, I think it takes special skills to say, let's see if this child really needs help. Yeah, I can see that the poll is clearly going in favor of needing a specialist, which is where we're going. Yeah, very easy. 96% says we need a specialist. Now, a little technical glitch here. Okay, I think, yeah, we're good. So the first thing comes medical. Let's rule out any medical reason for his behaviors. And how can you help as someone who's the first contact for this family? There is a chance the family may never seek medical help, and they'll just say, oh, he'll grow out. He's just 4. This is his first time going to school. But some will seek medical help and go to a family doctor or a pediatrician. And there are definite ways you can help before a specialist comes in. So a thorough developmental and medical history. There is a big role of parent education that comes here. And there are a variety of topics that Sam's parents may need education on. School phobia, anxiety, learning difficulties, there could be language delay. And very important, although I write this last, but I think I would like to speak more on this, is sometimes we just have to tell parents to reduce their expectations from a 4-year-old. It is so crucial to not expect a 4-year-old to match the hush and rush of day-to-day life that parents are expected to meet. And this is something very, very important when we talk to families. We want them to understand that they are 4-year-olds or they are little kids. Even if this kid is 6 and 8, they're still not adults. Their brain cannot function at that rate, and their emotional coping cannot be at the rate an adult really wants them to work. There is a big component of school advocacy that a primary caregiver can definitely do. I think what the school wants to hear is, yes, there's someone attending to this child, looking into his medical and developmental needs. And so once the school knows that referrals have been initiated, there are doctors involved, I think they calm down. They are reassured that this child is being looked after. But in addition to informing them that, yes, there are referrals done, I think they need to play their part. Giving some extra time to this child, not putting pressures, like if you come 10 minutes late, you have to go to the principal's office. Let's try to reduce some pressure. And it's a simple thing that a school can do. Gentle approach to behaviors, like if he hides under the table, let's not try to be too loud about it, or give him any punishment, or even consider that he's not listening or being rude. Let's try to have a gentle approach. Giving him more choices is sometimes so helpful, because kids at that age and stage where they're so much into their concrete learning, they feel more in control of their environment. Giving frequent movement breaks is very crucial. Our children need to move. Their occupation is to move and play. And so sometimes just giving breaks does all the magic. And nap times are also something that these days schools are not promoting, but if they can even give him some quiet time, I think it would be really helpful. And then, of course, referrals. As soon as we can, we would definitely pick this kid. Not going into the process that happens after those referrals are initiated. I just want to jump to what Sam had. Sam had social anxiety and sensory difficulties. It was a long process to come to this conclusion. However, what played the most important role was parent education and school advocacy while the team worked on Sam and his difficulties. So with this, I want to go into some didactic, very theoretical work about, challenging behaviors and what is their underlying. This is my most favorite slide. We only know the tip of the iceberg, and that's the behavior. Behavior is actually just the image of something that's underlying, which is so big and so intense. And you can see there are so many aspects of life, emotions, developmental skills, medical issues that can impact behavior. And if we can even take a thorough medical or developmental history that addresses most of these areas, I'm very sure we'll be able to help the child and the family. Going into the ABC model, so I'm only going to touch upon the most important aspects. It's a whole behavior analysis model. It's pretty complex, and I'm going to talk about just some of the aspects of these terms, but not go into details. There's adequate literature, and you're welcome to read it. So behavior, as we know, is what we can see, what is observed, and what is measurable. The A stands for antecedent, which really means what was the trigger before the behavior? What is the situation? Where is the child? And C is the consequence. And the consequences are extremely important because these decide whether the behavior will continue or not. So for example, if a child gets rewarded for any behavior, good or bad, the child is likely to continue this behavior. I want to give an example to better explain this. And so here we have our next poll question. We have the behavior where John pushes the chair and tables in the classroom. The teacher tells him to go to the principal's office.
Deepali, just to remind you that we have about 1.5 minutes after this to complete the presentation.
Okay. And so I can see, I don't want to spend too much time on the poll. I can see that we're going about 60% saying, yes, we rewarded the behavior. And then comes the management piece. There is a role for a family physician or a pediatrician. As I said, they can really go into a good history, analyze the behavior, and try to come up with a management plan. The teacher has a bigger role where they can give classroom accommodations. There is a manual, and all the teachers are likely to have this manual. Every behavior, as subtle as the child could have, there is an answer for this behavior. They have strategies and classroom ways to help the child. Of course, there is a role of a multidisciplinary team to come up with a medical diagnosis. And then we know that the parents have a very big role. When it comes to parents, I want to talk about some parenting programs. And I did not want to elaborate on these, but there are some very good parenting programs that parents can sign up for. These are all available on Eventbrite, and most of them are offered free. So these are really good parenting workshops. And then there are books. So these are, I know the PowerPoint slides will be available later on, and some very nice, simple reads. And these are books that can help most clinicians, parents I read these books when I have to help families. So they're really nice books written by some very well-known authors. And I just want to
just finish
say,
there?
it takes a village. It takes a village to help children. Early diagnosis is the key. And I know parent and teacher education will help us help all the kids in the school. My son is my teacher, actually, and I want to thank you all for helping school-age kids. So thank you so much, and I'm open for questions.
Thank you very much, Deepali. That was amazing talk. We have a couple of questions. I just wanted to start off, and I know this was a good distraction from the COVID pandemic, but it's really hard to get away from the COVID pandemic completely. My first question is somewhat related to that. From a developmental perspective, how has the pandemic, the isolation at home, the lack of control in the online schooling, how have you seen that affect the children that come to your clinic?
It has affected greatly. It's had different effects on different age groups. As we think about older kids, so 10 and over, I think the social piece has impacted. Their mental health, anxiety, depression, eating disorders are something we are seeing more these days. In the younger population, so the younger kids, the toddlers, I'm seeing a lot of social anxiety. Not talking to people and not going to closer to other kids is the norm. And so it has been extremely difficult for me to do assessments and even give any kind of diagnosis. Autism is so far away, but even giving diagnosis of anxiety or social anxiety or language delay has been extremely hard. The screen time, as Dr. Lung just mentioned, it has definitely been a major difficult part because parents are working and screens are unavoidable. And I think one last thing I have to say, that I've had parents come to me with typical kids, and there were some parents who said, I have a problem. My child doesn't unmute before he raises his hand. And I really had difficulty doing this. I really had difficulty handling this because she said he's expected to, raise his hands and then he has to unmute and he just cannot follow it. I think my child has ADHD, and that was very heartbreaking.
Thank you very much, Deepali. We're getting a few questions. The first question is a little bit about homeschooled children. And they just had a question of what your opinion was with homeschool children, what common problems do you see with this group of children, and whether there are pros and cons that you might observe. Did you hear that question, Deepali? You're still muted.
Yeah, no, I did. Homeschool, so just to clarify, I was actually reading the question, but homeschooling as in virtual school is...
It's not clear, but I would suspect like online schooling was, the big difference in the last year, so probably somewhat related.
Online school has pros and cons. I cannot say that online school is not for everyone, or because I have seen some of my patients who did better with online school than with in-person school. And so there's group of children, especially those kids who were anxious in the classroom, who were delayed and were having difficulty coping with the classroom demands. They did better with homeschool. But those children with ADHD, social difficulties, autism, they could not cope with online school. This is something that I saw in my clinic. Overall, I don't think it is physiological to keep a child in front of the screen for 6 hours. And if it was me, I wouldn't promote online school for anyone. even for those children who then got comfortable because they were anxious in a classroom, I still feel classroom exposure is kind of CBT for them. It's kind of cognitive behavior therapy for them. And so having that exposure is very important so that over time they can get through life and they can they can grow out of that anxiety. So I personally support classroom teaching.
Thank you very much, Dipali. Another question from Aviva Lau. What do you suggest for practical, timely professional support children with behavioral challenges? And I guess that they're asking about timely access to occupational therapy and other therapies.
Yeah, this is the hard part, and I'm sure we will soon be able to provide some support, not just in terms of assessment, but even therapeutic support through our program. The funding structure is very much concentrated on kids who have autism. I don't think there are any other developmental or mental health disorders that get any kind of provincial funding, except some parts here and there. Occupational therapists, speech therapists, they are very, very important to understand a child's development and needs. And I think most services are available privately, not through government sources. In Scarborough, we are the only full developmental program with an interdisciplinary team. But unfortunately, our wait list is over 6 months. So access is a big problem. We have started working on this, and I'm so thankful to our management who's supporting us in every way we want. We have launched our parent workshop part of the program. We just completed our 1 year yesterday, so it was a big celebration. There are some very important parent workshops, and these are all around typical and developmentally challenged kids. They are all available through Eventbrite, and the information is on our website. So I feel like this is where we've started, and we really hope to be available for a larger population.
Thank you very much. Maybe our last question, if we can squeeze it in very briefly. Nushad has asked, any suggestions for parents who have no choice but to do online school for their children? And perhaps he's referring to children with some special needs, but are in that situation.
If that is something that has to be done, that's okay. But I would say place very, very reasonable demands on the child. Very reasonable demands. I think if the child doesn't perform, has to repeat a year, it can be very hard for the family, but to slowly educate them that these pressures are not going to help the child. I think that's the message I would give.
Okay, thank you very much. I think that was a wonderful conversation we had and a great speaker. We thank you once again, Dr. Mankad, for coming with us tonight and sharing your experiences. We have a few housekeeping matters as we go further. After the break, which is coming up, there will be a feedback form, and we ask that all of you participate and complete the feedback form. It entitles you to 3.5 hours of the CME for attending and participating in tonight's conference. So I'll move on to our next speaker. So our next speaker is a very good friend of mine. I've known him for a long time. I consider him a mentor. He's a great person. I also love his biography. I think it's a very interesting and very reflective of who he is. So Dr. Roland Beaulieu is a pediatric cardiology consultant at the Scarborough Health Network and the North York General Hospital. He was the chief of pediatrics at the Rouge Valley Hospital System, the Ontario Medical Association chair section of pediatrics. Dr. Beaulieu is a teaching coordinator, community teacher at the University of Toronto to third-year medical students. He was the first to do fetal cardiology in East Metro since 1988. His interests include Kawasaki disease and Ehlers-Danlos syndrome and hypermobility syndromes, as well as dysautonomia and fetal cardiology, including effects of polyphenols on the premature narrowing of the fetal ductus. Dr. Beaulieu is the lucky husband of a nurse, Beverly Beaulieu, and has two lovely daughters, paramedic Julie and PhD in higher education candidate, Jacqueline. He is also the proud papa of a grandson, Carter, grade 2 student in Waterloo. He enjoys music, golf, photography, collecting and losing Lotto 649 tickets. Dr. Beaulieu hopes to never retire unless a stray winning 649 ticket changes his mind. I love that bio, it's a great one. Thank you very much, and all of us, please welcome Dr. Roland Beaulieu.
Thank you so much, Hubert. Let me just get my slides going here. Thank you everyone for attending tonight. I think we have my colleague to follow must be up quite late in England, but welcome to everyone. And let me just get this first slide done. You know, this whole COVID thing and vaccines and hearts is coming together, especially as the FDA has just approved the vaccine for the 5 to 11-year-olds. And you can imagine that group of children and their parents are very careful and do not want to expose them to any harm. On the other hand, we have the need for public health to reduce the number of people who are susceptible to this illness. I was just looking up today some things in the United States. There's been at least at this one point of article 8,300 hospitalizations for COVID. 1/3 were in the ICU, and they've had 100 deaths. This has been mainly the Delta strain, which has been kind of snuck up on everybody. We didn't realize that things can get worse, and that truly is what could happen. Things can get worse with the different variants. We don't know which organ it's going to affect, which age group it's going to affect. Having lived through SARS, which those of you who remember in Toronto in 2003, we all had to survive. The hospitals that we mentioned in the Scarborough Health Network were the main hospitals hit, as was the North York General Hospital. And having lived through that, I can tell you it was fear. And we had no tests, we had no swabs, we didn't know who carried SARS, we didn't know who carried what. And it was extremely difficult time, but I'm so proud of Public Health Basics. Dr. McGeer down at UHN helped us steer us through that episode. And I'm fairly confident that we're doing a pretty good job here in Ontario with our vaccination rates. Saskatchewan's had 124 children hospitalized, 20 admitted to ICU. So this is a disease, unfortunately, unless you know someone who's been hit by it, you may not take it too seriously. One of our colleagues in Markham Stouffville was hit by it, and I trained with him. And once you know someone personally, a friend, a family member, you realize that, no, this is real, and we need to be careful with this situation. So what I'd like to talk to you about is a little bit about what we're seeing in our office. We've had about just over 30 children now present to us with either myocarditis or pericarditis type symptoms. Many of you are those that have referred these children to see us. We see approximately 10% of the population of children in Ontario in our office. So if you were to multiply that up a little bit, that would be, there has to be at least 300 children in Ontario who've had this situation since the vaccine has been out for them since earlier this year. Here's a case, a boy that I looked after for many years. He has a small VSD. He did have some PVCs, which is interesting, and I suspect these were from some viral related illness he may have had younger, but they were going away. He was down about 50 a day and all was well. He had his first COVID vaccine shot in June this year. And about 4 weeks later, started noticing he was having a large number of palpitations per day. We did a Holter on him and he had 1,700 PVCs and a number of couplets. This was a huge change from his previous Holters. We did an echo on him. He had reduced function. We did do his troponin level, which came back normal, but this was 4 weeks later. And we were quite concerned about this boy having both arrhythmia and decreased function. He was placed on ibuprofen, and after 3 weeks, his EF ejection fraction did return to normal. However, his PVCs even became worse, and they're up to 29,000. And so we had to leave him on a high dose of ibuprofen for about 2 months now. And his PVCs are slowly coming down, but each time we wean him off the anti-inflammatory, his count was back up. He's currently around 14,000 PVCs, and we're doing a very slow taper. Now, this snapshot from Israel is showing when do children, young people get myocarditis. And we can see after the first injection, which is the top slide, you can get a few cases anywhere from 2 days all the way out to several weeks afterwards. And then after the second dose, males are the blue and females are the red. Very high incidence within the first 6 days after the shot. And so it seems to be the second dose. They primarily use Pfizer, I believe, in Israel. And this is what we have been seeing is a number of children within the first week and then several who are weeks later, even a month later can happen, and they get the symptoms of myopericarditis. I'm not too fussy over which they have. You can almost call it pancarditis, because some seem to lean more to pericarditis, but I don't think the virus, or in this case, the inflammation from the vaccine is pure cut. It doesn't just hit the pericardium. It doesn't just hit the myocardium. But this is what we are seeing, a group of early reactors within a few days. I had a girl today who reacted the instant she had her vaccination. This is too early to be pericarditis, myocarditis. Is much more likely an allergic reaction, but she had the same chest pain and discomforts, and she turned out to be more of an allergic type picture. So here's the first poll here. This is the, let's see if I can just move a little thing out of my eyesight here. Getting myocarditis from either COVID versus the vaccine. Which do you think is the more likelihood? The more likely answer? About equal? Is it greater to get it from the vaccine than the wild virus, which a lot of parents are a bit concerned about? Is it 6 times more likely from myocarditis? And then D, no one really knows. And I think you guys are spot on here. This is the correct answer here. I think we can end the poll. And the correct answer, to get rid of this little guy here. See if I can move my slide forward. Here we go. The 6 times more likely to get myocarditis from the virus compared to vaccine. And I would also say no one really knows. I think there's a lot of subclinical myocarditis and pericarditis going on. We have so many children coming to our office daily for murmurs and all sorts of things. And pre-COVID times, we have so many children who have a lot of pericardial fluid present. And most of these children have had a recent viral illness of whatever type. And so myocarditis and pericarditis is happening every day, every time someone has aches, muscle pains, fever, runny noses. Viruses don't stop at just your sinus mucosa. They go everywhere, including the heart, but you just tend not to feel it unless you're getting palpitations. And a lot of young children are not vocal enough to state that they have that. And pain from pericardial rubbing may not occur. And you can get silent pericarditis, silent myocarditis all the time from any virus that you name. Currently, the 12 to 30-year-old males is the highest risk group that we're finding. The estimated chance of getting myocarditis, and I think this is truly a guesstimate because we're not really assessing people close enough, but roughly 1 person in 2,000 in this age group is getting myocarditis from the virus, and about 1 in 13,000, this is where the 6 times comes from, are getting it from the vaccine. In my office as a pediatrician, I mean, we're all pediatricians and some of us do subspecialty, but I always try to remind the parents, when we had SARS, it was the SARS that was the big concern. With COVID, it is COVID virus that is the concern, not the vaccine, it's the virus. And this is something that we have to remind our parents that we're not giving a vaccine for a non-serious illness. This has the potential of becoming serious in any one of us. We just don't know the factors that are going to make us personally more susceptible. And then I do tell parents honestly, I'd say the most important reason why we're vaccinating the younger children is just to decrease the transmission in society. And the fewer little trees that are, I used the term sapling the other day, if we can fireproof these little saplings, when the virus comes along, there are no saplings to burn. And the fewer saplings that are susceptible, this thing will die out that way. And we all know that we're reaching herd immunity in Ontario, and I think we're seeing it. We're not flooding our hospitals anymore. A lot of cases will be subclinical, and I think we're missing both the myocarditis from the virus. I'm sure it's much higher than 1 in 2,000, but it can be very subtle. Now, what are we looking for? The symptoms kids are coming in with is they're getting chest pain, usually within 1 week of the vaccine, but can be several weeks later. And oddly enough, some of these kids, the pain stays. I'm not so sure it's always going to be cardiac pain or pericardial pain. I think they also get chest wall pain, and they may have a form of myositis, chest wall myositis. They may also have, I've not heard of this term, if anyone in the room's a respirologist, but I think they may have diaphragmitis. And I think this virus may be hurting them, and that's where they have painful difficulty on breathing. Is we never talk about the diaphragm having an itis, but I wouldn't mind someone in the chat group clarifying for me, is there a diaphragmitis? They get abnormal heart beating. They talk about their heart pounding and irregular beating. They may get some abdominal pain. This could be generalized, could be from the liver if they're really getting into trouble. And the pericardial kids just cannot lie down flat. One of our staff members had a vaccine done. She's not in this age group, and she could not lie down within a few days afterwards and developed pericarditis after her first dose. Female, which is unusual, right? On exam, people may have inappropriate tachycardia at rest, especially when they have no fever. So you kind of look for that inappropriate tachycardia. The myocardium is trying to keep up to decreased function. It will go tachycardic. Ectopic beats you may hear. The heart sounds may be muffled if there's enough fluid. You may hear a friction rub. Always lean the person forward when you're listening to them. Friction rubs are usually heard. Bend them all the way forward, almost to their knees, and you can hear the rub better in that position. You won't listen. You won't hear it in other positions often. They may have some chest wall pain. You may palpate areas of tenderness, and the liver may or may not be enlarged. On ECG, so we do send these kids to hospital emergencies. Thank you for all of you who have been seeing these children for us, because we need an ECG. We want to look for ST changes. We also want to look for any depression of PR interval. Those can be signs of pericarditis and myocarditis. A chest X-ray is always helpful. You never know if these kids have some underlying pneumonia. They may have coexistent COVID at the same time. They're going to need an echo at some point to check their function, look for effusions, and troponin. It's amazing how helpful this test really is. There are a lot of things that can throw off your troponin, but in this case, it's so helpful to know, is it normal or not? If it's not normal, then there's a high chance that we've got some issues going on with myocardial involvement. We wouldn't do MRI here in Canada. In the United States, they'll do MRIs a lot and look for edema and all the sorts of factors, but I don't think those are going to be necessary unless a child's in extreme heart failure and would have to be transferred to a tertiary center. Inflammatory markers are very helpful. CRP and ESR may or may not be elevated. CPK may be helpful to just check out for other myositis, because a lot of kids are complaining of chest wall pain. Do a COVID test as well, because you never know, they may have caught COVID either before their second dose. You can do, this is a paper from Matsubara in the US and doing strain echo. If you use sensitive tests like these kind of tests, you can detect decreased function. These are in children with MIS, and they were able to show early on some changes in their function. We don't have this available in our office, nor the hospital right now, but hopefully with the upgrades in our equipment, this is on most of the newer adult systems. What to do? The CPS has come out with some ideas about treating, and SickKids has, I believe, come up with this formula of some ibuprofen 10 per kilo TID for a week. Then you reduce it to 5 milligrams for a week. And you may have to kind of keep going down slowly from the Q8H to BID in some children if their symptoms persist. You may need a higher dose. You may need some colchicine if they're having some pericarditis. We try to hold off on steroids with pericarditis. It seems to cause a bit more of a lingering situation, and we don't want to go into a chronic pericarditis. These kids need to rest for 3 to 4 weeks, although my favorite is you got to rest 6 weeks after anything. That's the usual thing. Most symptoms disappear within a very short time. Now, what we're doing in our office
just
here,
1 minute left. Okay.
We are giving kids ibuprofen prophylactically now to high-risk kids. So they get 5 doses, 1 an hour before, and BID for 4 doses afterwards. Remember, Moderna is quite a bit stronger than Pfizer, but most kids are still getting Pfizer at 30 micrograms. The younger kids are going to get 10 micrograms. Exemptions for vaccine is if they've had myocarditis, pericarditis, they have reduced heart function, cardiomyopathies, arrhythmias, poorly controlled SVT, Kawasaki within the last 2 years. I don't know if these kids are safe to be exposed to this. Dr. McCrindle at Sick Kids says there's no reason he thinks they shouldn't be able to, but I'm a little more cautious and I'm waiting for some more evidence and any allergic reactions. Research questions: should males from 12 to 30 have, oh, sorry, I can just going to move out these pictures here, have a reduced dose of the vaccine? I was sorry that the CDC didn't come out with that or increase the intervals to 8 to 12 weeks. I think we're going to find the younger kids. I haven't heard yet what the interval is going to be between the 2 doses. There's some talk it could be 2 months or 3 months even, and also decrease exercise after you've been ill. So here we are. Will children less than 12 years old show the same number or amount of perimyocarditis as teens? We'll have to wait and see. And stay tuned, and I'm welcome to your questions.
Thank you very much, Roland. That was amazing. I mean, it's obviously something that all of us have really seen in our emergency departments and our practices in the last 6 months with the approval of the vaccine between the 12 and 17-year-olds. I think a lot of us hold our breaths a little bit to see how the school-age children will respond. And so, you're right. It's a interesting world we live in, and we have to give correct and accurate information to families, and we also have to promote vaccination to ensure that all of us stay healthy and safe. Okay, so I welcome any questions that anyone might have. You can certainly write them in the chat, and then we'll be happy to kind of bring them to Dr. Beaulieu's attention while we have his time with us. To start off the question, I just wanted to ask, in terms of like emergencies and therapeutic interventions for some of these children who do present with myocarditis, pericarditis, at what point are you saying to yourself, well, this kid looks a little bit sicker, and maybe we should monitor that one in the hospital overnight? What type of features would you be looking for?
Well, I mean, you got to look at the symptoms. You got to look at your blood pressure, your heart rates, how comfortable this child can be, getting your x-ray, if you got a bit of cardiomegaly. But I think you're going to have you're going to have to give them some kind of anti-inflammatory. It's going to take a little while to kick in. So I wouldn't have a problem with you keeping a number of these children overnight for observation. Unfortunately, we don't have, you can't, there are some hospitals that do point of care ultrasound in their emergency rooms. I think Sick Kids does it. I know North General does it, and a few others. We did have a recent child where that test was quite off from the reality. But I would just say, if the symptoms are severe, I would definitely keep them in overnight. If the pain is that severe, get your troponin levels. And many of you have done a wonderful job of getting a baseline, maybe repeating it in a number of hours and watching for that change. And you can shoot up to, from a few hundred all the way up into the thousands. And so we realize that this child is at the early stage of their myocardial injury. And it's almost like there's this inflammation. And I think for some reason, males, they get their first dose and injure their myocardium slightly, and they recover. And if the second dose comes on too quickly, then they're re-injuring that injury. It's almost like a concussion after an early concussion. How far apart do you want your concussions? Do you want them 3 weeks apart or 8 weeks apart? And if you haven't healed that first one, but the troponin, unfortunately, cannot get as an outpatient. So those of you in clinics and that, I think if you're in a clinic in a hospital, maybe you can correct me, Hubert and Actor, can you get a troponin level done in a hospital clinic, outpatient clinic?
In the emergency, yes. For an outpatient, if you're having a daycare or something, but to get it done quickly, it depends. If you are in an emergency setting, it gets done quickly.
And if you have a hospitalized child that you're keeping overnight, you're able to do a repeat?
Yes,
yes. Yeah. That's the problem. We're a little bit stuck with having to admit the child or at least go to emergency, which is difficult even accessing emergency as it was in March. But I'm hoping now that the numbers will be that we have accessibility to troponin.
Okay, so we are having a couple of questions, but we have a little bit of a time restraint. After this, we're going to have a little mini break for people to stretch their legs before we get into our keynote speaker as well. So the next question comes from Diana. She's asking, what is your view of taking Advil after getting the COVID vaccine to prevent myopericarditis, I presume as a prophylaxis?
Yeah, no, what I've been doing to all our males, I think it actually should be standard for the time being, is I think we need to subdue. I think the dose is too high. The 30 micrograms is probably too high for teenage males. And I think somewhere, somehow, someone needs to do, when you do these trials, I think you should learn that maybe we need to do another trial. And so take that age group of males that are at high risk and try a different level, a lower dose, and see if you can still get adequate antibody response. And then we can find that out. Because this was done in a hurry, relatively speaking. I don't believe the trial may have done enough fine tuning. So now you see an issue, you should go back to a trial, redesign another study, and enter males into a multiple dosing thing, and then time frame. And do the time frame as well. And in the FDA, when I was reading, they're thinking of these 5-year-olds to 11-year-olds. Maybe it could be a 2-month space. It could be even a 3-month space. And so I think they're learning that we got to be careful not to invigorate the immune system too much. And for some reason, there's some people who overdo it. And that's how I teach the parents. I said, girls, ideally in this young age group, 6 weeks apart, boys, 8 weeks apart. Boys, I would prophylax every one of them. If I had a son, I have a grandson. So if I can talk my daughters and son-in-law into it, I would probably recommend doing it. Now, there may be the speaker to follow may have some information on that, and anyone with immunology out there may say, but you should really do a proper trial to see how that affects the eventual antibody response. I agree. But in the short term, the CDC let me down. They did not alter the dose. They did not alter the interval. And so I had to come up with what I think is the right thing to do. So I highly recommend that you do it on all males between 12 and 30 years old.
Yeah, it's a very interesting comment. I mean, there's one thing about the studies, the delay in how that research comes out, the delay in the reaction and recommendations and how the guidance has changed. And then there's our actual practice because we see those patients every day. So there's a little bit of a disconnect or a time lag where that changes. Our next question comes from Ruth. She's asking something similar. Is there any role for avoiding exertion or activity following the vaccination? Similar as a prophylaxis, I guess.
And absolutely. And I think there are a lot of, I tell all my patients to take the week off after the vaccine. There's no hockey camp, no hockey tournaments, no dance tournaments or whatever they are. You are exposing your body and your heart, and you can get an arrhythmia. And that's the scary part, is the myocarditis may not only hit muscle cells, it can hit your heart rhythm, as the boy that I presented as our case. So he's got a rhythmitis. I'm not sure what the correct term is for the rhythm system being involved, but they should actually do another study where these kids should be holtered for a few days afterwards and see what is the incidence of ectopy. And it might be quite somewhat alarming that there is quite a change in ectopy. Can you imagine having a sensitized myocardium and electrocardiogram and you going to a hockey tournament in 3 days? That's the unknown. And how many kids have died playing sports in shortly thereafter? They have done studies on NCAA athletes, and they seem to resolve their myocarditis fairly early. So I would just recommend to all people, anyone who's having their vaccine, take it easy for the first 3 to 7 days after your vaccine. Just play it safe. if you feel any symptoms, especially if getting any, especially your second dose for sure, that's, from the Israel, you got to learn from data. And the data says that 3 to 7 day mark after your second dose is probably not the time to go on a marathon.
I think that's all of our time for the question and answering. If anyone has outstanding questions, feel free to reach out to us and we'll put you in contact with Dr. Beaulieu. At this point, we have a very short 2-minute break so everybody can take a little rest, stretch, go get a drink. And then we're going to start our keynote speaker after that. And I'll introduce him at 5:57 just in a couple minutes. Thank you, Dr. Beaulieu. Thank you, everyone. And all of you, I will see you in a couple minutes. Okay, so welcome back, everybody. I hope you all had a little bit of a break there. First, I would also like to promote the Dottie Nicholas's upcoming event. She's a great person, and I think all of us would be better off just spending a couple minutes supporting her charitable foundation. Now, I have the great honor of introducing Dr. Hamid Merchant. Hamid Merchant is the subject lead in pharmacy and the course leader at the postgraduate suite of pharmacy programs at the University of Huddersfield. Hamid is an adjunct professor at the Health Services Academy, Government of Pakistan. He has over 18 years of experience in the pharmaceutical research and development, both from the industry and academia. His expertise includes novel formulation design, biopharmaceuticals, pharmacokinetics, bioavailability, and bioequivalence. His clinical knowledge and expertise in the pharmaceutical formulation helps in understanding the clinical and therapeutic principles underpinning the science of dosage form design and develop innovative solutions to improve the delivery and efficacy of medicines. Dr. Merchant has also contributed significantly to the safe use of medicines amid the pandemic. Before joining Huddersfield, Dr. Merchant has been associated with the University College of London, where he investigated various technologies for drug delivery into the gastrointestinal tract and offered technical support and expert advice to collaborators and clients from academia and industry on various formulations and drug delivery aspects. Hamid has also worked with the Abbott Laboratories Limited, and he's part of the editorial board for a variety of scientific journals. Hamid is a fellow of the Higher Education Academy, a member of the Royal Pharmaceutical Society of Great Britain, American Association of Pharmaceutical Scientists, Controlled Release Society, and the Academy of Pharmaceutical Sciences in Great Britain. Welcome, Dr. Hamid Merchant. On behalf of all the Scarborough Health Network, we are very pleased to have you with us tonight and happy to hear your speech.
Thank you very much for the long introduction. And I would like to thank the Scarborough Health Network for the invitation to present at this event, and all the participants who have stayed that long to listen to the talk. So thank you very much, everyone, for staying with us and inviting me to speak over today. So I would be talking about COVID vaccines in children, and it was nice listening to the talk from Dr. Beaulieu. It's always important to see how the clinical picture is presented in the hospitals and how cardiologists are looking at the clinical case presentations of the patients in the hospital and try to correlate it with what we see on the back end in the scientific development in discovery and pharmacovigilance side. So thank you very much for the nice talk, Dr. Beaulieu. I will try to correlate some of the things you have already mentioned and try to link up with some scientific, explanations, if possible, to explain some of those events. So before I get into talking about pediatric COVID vaccine challenges and how we could improve the safety in pediatric population, I'm going to go through some of the background of how these formulations have been developed, how the COVID vaccines has been formulated. I'm going to give you an overview of different types of vaccine formulations we have deployed across the world, particularly in our Western society here, and then we'll try to link some of the events related to the preclinical trials, clinical trials, and what we see as a moving forward to improve safety outcomes. So as you all are aware that we have got genetic vaccines relying on gene delivery principles, which includes mRNA vaccines and viral vector vaccines. And we also have conventional vaccines, which used the conventional technology of inactivated virus, or split virilon, if you like. In case of flu jabs, you have seen that. And the parts of the virus, for example, the recombinant proteins, for example, spike protein in this particular case. And typically in the past, we had subunit protein vaccines already for other conditions. So these are the main types of COVID vaccines being deployed across the world in different parts of the world, in different countries, depending on availability and access. Different countries and governments tapped into the vaccine formulations available to them. One of the early vaccines launched in some part of the world were from China, Sinopharm and Sinovac. They both relied on conventional inactivated whole virus technology. So this is based on flu vaccine design, if you like. These were not cleverly adjuvanted products at that time. They just had classic alum-based foundations to have the antigens absorbed into. There is slight difference between the two products. They use slight different variants of SARS-CoV-2, which was prevalent in the early 2021 and late 2020 in China at that time. So both are inactivated virus vaccine. One came out from the governmental initiative. The other one is a private sector vaccine. Both are now WHO approved, and Sinovac, which is one of the private sector vaccine, is also under European Medicines Agency review for the European markets. The another inactivated virus vaccine which came out from India was Covaxin from Bharat Biotech. This was very similar to the design from the Sinopharm, if you like, but it had a clever adjuvant with the TLR7/8 agonist in there. What this particular adjuvant does is a agonist which induces the B lymphocytes. And in clinical trials, we've seen that this strategy improves the antibody response many folds compared to non-adjuvanted vaccine. This is not a very new adjuvant being used before in other vaccines, and we had some safety and efficacy data available for that already. Normally, these type of adjuvants are preferred in immunocompromised or elderly populations where we expect a weak immune response from inactivated or killed virus vaccine. And that's the key difference between these two products. This vaccine is also being deployed in many parts of the world. Bear in mind, this is different to AstraZeneca vaccine, which is produced by Serum Institute in India. Another interesting vaccine, which many people might not be aware of, this French vaccine called Valneva. This was manufactured in Scotland in United Kingdom. This was heavily funded in the beginning and pre-ordered by the UK government as well. This is a beautifully designed inactivated virus vaccine and also contains CpG 108 adjuvant system. This adjuvant is from Dynavax. It's again TLR9 agonist, which improves the beta lymphocyte function and increases manifold antibody response remarkably in clinical trials. This is again not a new adjuvant. This is being used before in Hep B vaccine, for example, and there's a good data for the Valneva in clinical trials in the UK. Last week, Valneva published head-to-head clinical trial results in the UK study, which looked at the mix and match vaccines, and it outperformed AstraZeneca vaccine efficacy results, just came out today. Another interesting vaccine in Canadian perspective is Medicago's vaccine, which was viral-like particles being made by recombinant DNA technology. And this uses GSK's adjuvant, which was also part of many of the GSK's vaccine portfolio, for example, swine flu vaccines in the past. This AS03 adjuvant from GSK had also been off license to Clever Pharmaceuticals in China for another vaccine candidate formulation. But these products have not gone through the phase 3 trials quite yet. The Medicago's product is going through phase 1 and 2 clinical trials in Japan, just started in October, early this month. Interestingly, same adjuvant being off license to Sanofi as well, and Sanofi's inactivated again this recombinant protein subunit protein vaccine, which has also been adjuvanted with the same GSK's AS303 adjuvant system. This has gone through clinical trials, and EMA started rolling review in July in 2021. So the approval might be imminent for this particular product. Novavax was another vaccine which has been, on the limelight for many immunologists since a while. This is also subunit spike protein vaccine, which is encapsulated in a nanoparticulate drug delivery system. This is also being manufactured using our DNA technology. And the secret ingredient in this particular vaccine is also matrix M adjuvanted system, which comes from a second in Chilean soapbark tree. This is a natural ingredient that comes out of the plant bark, which is a very highly potent adjuvant to induce beta lymphocytes and antibody response. You might have heard in news recently, the vaccine group in Oxford University has met for the first time malarial vaccine WHO targets. And the magic ingredient in that malarial vaccine was also the matrix M from Novavax. It's a proprietary adjuvant which is struggling with the supply chain demand and purification isolation process from the plant source to come out into the product. The vaccine has been significantly delayed to come out in the market, but the company is aiming to put the millions of doses out into the market by the end of this year. The efficacy trial was done in UK and the results were very good, and particularly the efficacy was very good against the variants in circulation earlier in 2021. The mRNA vaccines, which has been dominating the world, particularly in America, US, UK, and Canada as well. These type of vaccines uses the mRNA encoding the gene for the spike protein in coronavirus. And these mRNAs then encapsulated into a very proprietary solid lipid nanoparticulate drug delivery system. What this nanoparticulate drug delivery system does is it functions like the nucleocapsid protein coat, which protects the mRNA in the actual virus. And this shields the mRNA from cellular enzymatic attack. mRNA itself is a highly susceptible molecule in the body. It hydrolyzes very quickly. Its stability is very weak, very low. And this proprietary formulation system protects the mRNA to be destroyed by the cellular enzymes and allows the mRNA to be delivered inside the cell before it's been hydrolyzed. So once this vaccine has been injected, these nanoparticles makes its way to the muscles and goes down inside the cells. These mRNA molecules do not need to go into the nucleus. They work in the cytoplasm, they translate, and mRNA translation leads to spike protein production, which then presents itself outside the cell surface, but like coronavirus does, and that attracts the antibody response. It's important to understand this mechanism because these vaccine transfected cells, which would then require clearing up from the immune system, is then the result of the antibodies or the T cell response, which is what we require in these patients. The examples of these type of vaccines across the world is Pfizer, Moderna, as you are already aware of. These vaccines are very different in their mechanism of action and the formulation strategy compared to inactivated virus vaccine, because these ones actively engage the cell to produce spike proteins and then expect a very good immune response to mop them up, compared to inactivated virus vaccines, which do not rely on that principle. You just inject either pre-prepared part of the virus or the whole inactivated virus, which the immune system clears off later. The other type of vaccines that we have includes the viral vector vaccines, which takes the spike protein gene again, and which has been then incorporated into an adenoviral vector system. So adenoviral vectors are viruses which are silenced, so they do not have the capability to multiply. If they go inside the body, they would not infect and start the chain reaction. And the DNA has been modified to incorporate the spike gene from the coronavirus. These vaccines has to penetrate through the cytoplasm once injected into the nucleus, and then this DNA would then transcribe into mRNA, which comes out into the cytoplasm to produce spike proteins. Once spike proteins are being produced, they again present themselves on the cell surface, and there's an immune system response against those vaccine transfected cells in the body. Again, these vaccines are very different to conventional vaccines because they actively engage into our cellular machinery and instruct the cells to produce part of the viral antigen themselves. And then it requires a very good immune response from the body to not only clear the vaccine transfected cells, but also clear off the adenoviral vector. Adenoviral vectors are type of viruses which are common to human beings and population, and many people do have some pre-existing immunity against adenoviruses, which are found commonly in the society. AstraZeneca uses a chimpanzee-based adenoviral vector to overcome the problem of pre-existing antibodies or immunity against the vector system, whereas CanSino Bio used the human 85 adenoviral vector system. We have single-dose vaccine from Johnson & Johnson, which also used the human version of adenoviral vector. Then we had a Russian vaccine called Sputnik 5, which uses a dual viral vector system, 85 and 8026, to avoid the loss of vaccine function in the second dose when the body produces enough antibody response against the vector itself. So they've got a different formulation design when they have got two different vectors in first and second dose to overcome that barrier from the immune system to have the maximum potency. So CanSino Bio uses 85 system, Janssen uses 8026, and Sputnik uses 8026 and 85 both. And this particularly improves the prime boost function by changing the viral vector in Sputnik system, which we see is a problem in other viral vector-based vaccine. This has been one of the reasons why some viral vector vaccine went ahead with a single dose regimen instead of a 2-dose, because then after the single dose, the immunity against the viral vector itself destroys the second dose if it's been too quick from the point. Some vaccine producers increase the dosage regimens and the duration between the 2 doses. For example, AstraZeneca has been increased to 12 weeks to allow the second dose to function again, and the antibodies against ADV vector subside with time. So before we move on to the next part of the presentation, there's a poll on your screen, and this is a very common question which comes around into discussions with the colleagues and social media, newspapers all the time. And let's see how people think about different responses here, and we'll go through the next part of the presentation. Thank you very much for responding. As we can see, majority, 76% people thought benefit outweighs risk for all population, all pediatric population, and some people think benefit outweighs risk for some. We'll go through our next part of the presentation. We'll discuss the options later down in the presentation. So this is the age distribution of the COVID deaths in United Kingdom, particularly the NHS England data in 2020 before the vaccine rollout. And this shows the age groups which were severely affected in terms of the worst outcome from COVID-19, which is death. And 98% of all COVID deaths in England was in people above 50 years or old. If we looked at the post-vaccine rollout results recently, this is the data coming from last 3 months from July to September after the Delta outbreak in England. And we can still see that the majority of the deaths are dominating in the higher age group. So for example, 50 plus dominates, again, 98% or so of the deaths. There are still some mortalities in younger population, which is worth looking at. And there are children with high risk living with some comorbidities and some health conditions, which increases their risk of catching a severe COVID, hospitalization, and death. So we cannot ignore children because they represent a small fraction of population who died with the disease, but majority of children would have minor to mild COVID-19 and would not have a severe risk to die with the disease. The other motivation we have for vaccinating children is reduce their suffering. So COVID-19 is a serious viral infection which causes children to suffer, although they do recover. But if it's a preventable condition, the prevention is better than cure. And we would like to reduce children's suffering from the condition and reduce the risk of hospitalization and particularly burden on healthcare facilities. So although kids are not at a very high risk of dying from the condition, but when they go out to the NHS hospitals, then they occupy the health resources, which then will not be available to other high priority patients, and routine surgical operations needs to be done. So there's issue with the capacities in the hospitals, intensive care units, pediatric units, and offering routine care to the other patients as well. So if we could prevent the risk of hospitalization and burden on healthcare, then the vaccines are worth to have in children. And also impact on their education and schools has been very high in the COVID-19 scenario, and we would like to reduce the adverse impact on education down the line. Also, kids have been one of the reasons of spread across the community in the households, passing it on to vulnerable family members, and that's another risk which we would like to have vaccines to prevent those. So there's a multi-point agenda why we would like to vaccinate children, and the benefits in the kids population is very important to look at, not just from the mortality benefit, but also with the all other benefits associated with vaccination in children. And that has been discussion in NACI in Canada. It has also been a discussion point in JCVI, which is the Vaccine Advisory NACI equivalent group in the UK. And this has been cause of big debate about the benefits to kids themselves for the COVID vaccines to allow the national immunization drives. This was the data presented earlier in the ACIP meeting in FDA, where they looked at the rates of myocarditis and pericarditis in young males, and the observed rates were significantly higher than what would you expect in this age population. And there's a clear difference between gender, and there's a clear difference between the first dose and the second dose. And this caused lots of concerns and discussions in all advisory committee meetings to review the decisions based on the facts we have and the benefits and the risk balance between these populations. One of the key points which Dr. Bulli also discussed in his presentation is the manifestation of myocarditis and pericarditis. One factor which is important to look at here is that when we do work out the rates of myocarditis in after vaccine or with the disease, we look at the number of doses administered. And often we know that the second dose triggers myocarditis more than the first dose, but the denominator is per dose. And if every subject in this study had 2 vaccines being administered, then if you normalize the data with per patient, then the rate's going to be further high. So there's a denominator here which would give us a slightly different picture. So this is what we can do the best analysis at the moment, but there are finer details of how the risk has been calculated post-vaccines and the risk calculated with the actual disease. For instance, subclinical myocarditis is an important issue post-vaccination, which often does not develop into clinical manifestations of myocarditis. So if you look at pharmacovigilance from US and the MHRA's UK data, we do see thousands of reports bringing up a very strong signal on rate and rhythm anomalies in young patients, young children, and younger adults, or people in 20s and 30s with the vaccine, particularly with Pfizer and AstraZeneca, both vaccines. And those rate and rhythm anomalies may end up into myocarditis or pericarditis and may not they may resolve themselves. So the actual rate of myocarditis or subclinical myocarditis is very difficult to estimate at this time. And all those thousands of yellow card reports we have, it's very difficult to investigate to every single patient detail. And that might change the risk benefit equation if we go into that detail. The another factor which is important to look at is the actual COVID-19 related myocarditis in children. And one of the key issues we have that all the calculations we have done is in the children which have a moderate to high or severe COVID-19. There were lots of children in 2020 who had asymptomatic COVID-19, which did not capture into the data for the calculations, and they might not have a very high risk of myocarditis. So when we compare the risk of myocarditis with the actual virus compared to vaccine, we're only looking at moderate to severely ill pediatric population, and not everybody who got COVID-19 in pediatric population, which again changes the risk balance curve slightly. But this is the best data we have. And it's difficult to work out the actual prevalence in the population with the complexities we have at the moment. The other issue we have is the incidences of Guillain-Barré syndrome and neuropathies, particularly peripheral neuropathies. And some of this is down to the injection technique. And we're trying to look at this particular perspective, and some may be related to the direct needle injury to the patient and accidental involvement of auxiliary nerves or facial cranial nerve which goes around. Or it could be because of the positioning of the needle, where you do not puncture the nerve directly, but you inject very in the close proximity of the nerve, which again causes a concentration gradient and efflux of the vaccine into the nerves. And bear in mind, these gene delivery based systems would transfect the mRNA into the nerve cells, which would then present itself for the spike proteins and attract an immune response against the nerve cells. So there might be a transient issue where the immune system starts attacking those cells which are being transfected with the vaccine, but it might resolve itself once the vaccine transfected cells are cleared off. But in some fraction of population, this might end up into a chronic condition. There is also a vasculature involved in the muscles, and the last thing we want is these vaccines to go down to the vasculature. These vaccines are designed to stay into the local area, drain through the lymph nodes, and then produce the immune response locally there. This would again drain down to the liver through the lymphatic system, but we do not want the vaccine to go down to the other vasculature. And that could lead to vaccine antigen being delivered into the distant tissues, vaccine transfection to other tissues, maybe, for example, myocarditis being caused by transfection to the cardiac tissues, myocardium or pericardium, leading to an immune response against it. If you look at other factors which we could do here is the competency-based training of all vaccination staff, and try to look at how we can improve the injection accuracy. There had been lots of injection technique errors in the phase 3 clinical trials reported by the vaccine companies themselves as well. So it's an important point to consider to improve vaccine safety, particularly in pediatric population, because we're dealing with people with very small deltoid muscle mass into the arms. So that it raises lots of questions about the injection technique, needle size, injection dose volume, not just the antigenic load, but also the volume you inject into that tiny piece of muscle there. So if you look at the Moderna, it's a 0.5 ml dose with 100 microgram antigenic load per dose in adults, and Pfizer only at a 30 microgram in 0.3 ml system. 0.3 ml is a relatively smaller dose, and antigenic load is also very low, which might be better sitting into the local tissues compared to a bigger size dose volume injected into the tissues. It also depends on the body mass index, the size of the muscle on the arm. And for the recent pediatric recommendation, Pfizer has gone down to 10 microgram. So I do recall Dr. Bullion talking about that. We did had some evidence in phase 1 where we did dose escalation studies, And we can, at that point, we already had phase 1 immunogenicity data for 10 microgram versus 30 microgram. So lots of studies do not have to be repeated. The data is available. Pfizer went ahead with a 30 microgram dose at that time because that produced the best outcomes. But the 10 microgram dose was very well tolerated. Safety was a lot better, but the efficacy was lower compared to 30. That's why in the phase 1 dose escalation studies, they went ahead with a higher dose. But 10 microgram has been trialed before in phase 1, and that could be one of the recommendations to look at. And also not just looking at the age. For example, somebody who's 12 years old might have a very lean muscle mass compared to somebody who is 10 years old or somebody who is 20 years old. So the research questions here is to look at the body mass index or maybe lean body mass rather than the age itself, and weigh those boundaries of age to look at the dosing regimens. Maybe we go for a 10 microgram dose in high-risk individuals with a low body mass index, or particularly male gender, which we know are at a higher risk. In terms of
Dr. Hamid, sorry, Dr. Mersham, we just only have a minute left, so I just wanted to keep track of the time.
No worries, I'll try to wrap it up in a couple of minutes. So we do, the other consideration for the vaccine safety includes the syringe size. So intramuscular syringe is quite a lot longer. So that's something we can look at if a maybe sub-Q syringe size or maybe a different syringe size might be more appropriate for younger population in pediatrics. Also look at the dose volume, maybe reducing the dose volume further, or completely looking at a different muscles, for example, gluteus muscle instead of deltoid muscle. Lots of pediatricians, attending the event today, and you might be aware of age brackets for other vaccines where the vaccines are contraindicated in deltoid muscle and has to be injected in gluteus muscle for the same reason. So that's something we need to look at. The recent data from ONS came out last week, also emphasize on protection from the natural infection. This has been a very political issue in the US, but this has come out in UK from the government last week, and it's very important consideration to look at. The government currently in the UK is only offering a single dose Pfizer to 16 to 18 years old. So that could be something which Canadian authorities can also look at to improve the vaccine safety in this particular age group. So UK government will decide on the second dose down the line, and they don't want to jump on offering 2 doses at the moment. 2 doses are offered to 12 to 16 only high-risk groups now, and the duration is increased to 8 weeks. The other issue with the convalescent kids, because those children who already have exposure to COVID-19, whether symptomatic or asymptomatic. So we have a very good seroprevalence database in the UK from Public Health England, which looks at the seroconversion in population, and also looks at the blood donors and seroconversion rates from there. And it's very easy to look at in UK because we only have mRNA or DNA-based vaccines. So the antibody tests can differentiate between natural infection versus vaccine-induced immunity very well. So there is an important question as to how many doses you need to offer to convalescent kids, particularly kids who have got severe illness and has been hospitalized. Do you want to give them vaccine immediately? You want to wait longer? So all these safety points would ensure individual customization depending on the patient itself. So the current data from ONS clearly suggests that maybe first dose would be enough for all these people who have got pre-exposure to the virus as a booster, so they do not need 2 doses. The worst thing we want is to have an antigenic overload and give too much antigen in a short period of time, which would again cause more safety issues. Considering the situation, lockdown being lifted, majority of kids and young populations are socializing again, and there is a high percentage of people with an exposure, whether symptomatic or asymptomatic, in the community settings now. So that's something we can build on. Our recommendation would again coincide with what Dr. Bulia said. We would suggest that all children and young adults, particularly males, should avoid any extraneous exercises, sports activities, physical activities during the acute phase. In clinical trials, we've seen the acute phase last between 14 to 21 days, and that's the period we would like people to look at that. Also, try to keep a gap between the vaccines, COVID vaccines and other vaccines, for example. So there's a recommendation from NACI, which you can look at. And ibuprofen, paracetamol, post-vaccine prophylaxis is definitely something people should look at. So if people try to get the kids vaccine in the afternoon and then have a nighttime paracetamol, ibuprofen to go to the bed, that would prevent a lot of early onset symptoms. Lots of the most frequent observation after Pfizer vaccine or mRNA vaccine is the temperature and chills, which require ibuprofen, paracetamol anyway. So post-vaccine prophylaxis is very important, not to have those chills and fever onset before you start taking them. And then one request to all healthcare professionals that do report all suspected adverse events. You do not need to make sure that they have a causal relationship. It's very important for healthcare authorities, for example, Health Canada, to look at the cluster of events coming out from different parts of the countries. And sometimes those helps to put the jigsaw together and run some further investigations. So even if you think it might not be related to the vaccine, please do report all suspected adverse events, which is part of the legal requirement anyways. Some high risk groups I want to just highlight. I'm sorry, I'm running out of time, but if I have got just 1 more minute, I just want to run this very quickly. Because these vaccines require active involvement of the immune system to clear the vaccine transfected cells. So there are populations which might not have a very good immune response, which might mean that the vaccine transfected cells will linger on for a bit long. The spike protein might get into circulation, and that might lead to some safety concerns. So there is a high-risk population needs to be closely monitored. So if one of these kind of conditions, immunocompromised kids, particularly those on kidney transplant, for example, or solid organ transplant, people on chronic immunosuppression, chronic use of steroids, some targeted B lymphocyte antibodies in rheumatology, for example, rituximab, those kind of patients needs to be closely monitored because they will not be able to clear off the vaccine transfected cells very quickly. You might need to monitor them. You might need to delay the second dose. You might not need to give a second dose, rather, if there are problems in those. Hepatic issues is one thing. There are 2 new lipids in the vaccine formulations which have not been used in humans before, and the toxicological data suggests that one of the lipid has a capacity to accumulate in the liver. We don't know if this comes out later or are there any associated liver damages with that particular ingredient, but this has been mainly cleared by phase 2 glucuronidation reaction, which is normally slow. And some of the mice data from Pfizer do suggest some liver injury and elevation of liver enzyme. So there's a caution here if the pediatric population have got any liver issues, have been in the past with hepatitis or any other liver issues, maybe autoimmune hepatitis or a viral hepatitis or PBC kind of conditions, then those patients need to be closely monitored as well. So if you look at why we want to vaccinate kids compared to the challenges we have, we do have vaccines which are very effective in reducing risk of hospitalization and death, but they do rely on circulating antibodies, and there is still a risk of catching the infection because they do not produce mucosal antibodies. The risk of mild infection will always be there, and the community spread may not be able to be controlled because these kids will still catch a very mild infection, would still be passing into the community. And there are issues with pericarditis and myocarditis. So this is something we need to look in mind, and that links into the nasal flu vaccine, which we have. And this vaccine just introduced a few years ago in the public health settings. This has been used for a number of years now in old school age going children in UK, quadrivalent vaccine, and it provides the mucosal IgA response into the kids, which actually prevents the infection and community spread. And there are lots of head-to-head clinical trials with injectable vaccines to show the efficacy in preventing kids to catch it and transmit. So prevention and transmission is the key in children population. And the good news is that we have nasal COVID vaccines in the pipeline. The top runner is AstraZeneca, gone through now clinical efficacy trials. We've got one product from Lancaster in the UK, which is going through WHO COVAX facility. There's one Chinese player, CanSino, advancing very quickly into this domain. Russians are in place. And India is also coming up with a candidate. There's one coming from France, and there's also one coming from Taiwan. So there are quite a lot of products in the pipeline. In stage 2 immunization, we'll see lots of revised vaccines, new version of vaccines, and we will have a lot more options. So to sum up at the end, there's no right answer here. The risk-benefit ratio varies between individuals, and it actually depends on what vaccine formulations you are offering to the children and what pre-existing health conditions they have. So one-size-fit approach doesn't work for everybody, and our recommendation would be to personalize as much as we can. Just do not treat old kids as same, and that would improve the vaccine efficacy, so vaccine safety. Thank you very much. I'm sorry to run a bit longer than anticipated, but if there is
that was an excellent presentation. I found it super interesting, and I'm very grateful. I think I represent everybody, or speak on behalf of everybody, in thanking you for participating all the way from United Kingdom. I'm sure it's very late for you right now, but we are very grateful for having the opportunity for you to speak and for us to hear your talk. I think at this point, we're going to have a very brief panel session of questions with myself, Dr. Hamid, and Dr. Beaulieu. In addition, we'll be taking some questions from the participants as well. In the interest of time, I'm going to start off my question with one of the participants. Following this, I just also want to mention that we will have another short, a little bit longer break for 8 minutes to actually, so that we can rest before the second half of the sessions. So I'll start with the first question on the chat. NACI has now removed the pre and post waiting period for administering another vaccination. I don't know, I guess they're asking if you have any comments related to
that. You specifically asking about the gap between 2 vaccination recommended but not.
Yeah.
So the current recommendation is that you wait at least 21 days after COVID vaccine before you give kids any other vaccine. So some countries are offering, for example, COVID and flu together. So looking at the COVID vaccine and the acute phase response after the vaccine is very severe response, and you would need time for body to recover before you put another quadrivalent antigen into the patient's body, where the immune system hasn't dealt with the other antigen. If people would have got flu vaccine first, then the requirement is only 7 to 14 days before you give the COVID vaccine. So it's a lot more shorter period if you've got any other vaccine. But if you've got the COVID vaccine first, then it's at least 21 days recommendation from NACI.
Hi, Dr. Merchant. I wanted to ask you, when do we need a new vaccine for the strain? So Delta strain, is that difficult to have this update? Because it seems to me that at some point we need an update to include either the current variants or potentially the one that's going to come next year if it's going to keep doing like flu. How difficult is it to make a Delta specific vaccine?
I'm glad you asked this question. The good news is that the revised vaccines are already being formulated, and they're going through some trials at the moment. There is a mRNA vaccine from Germany as well, and they've just withdrawn their top runner vaccine candidate from the regulatory approval just because they want to prioritize their next generation COVID vaccine. So they've just dumped their first generation candidate, which has gone through phase 3. So need to come out, but there is no need now. Everybody is vaccinated. So the good news is revised vaccines are already there. The mRNA vaccines are relatively quicker to revise based on the DNA template and the production system we have. The inactivated virus vaccines are the longest because of the tedious manufacturing method. They need to be propagated either on cell lines or on chicken embryos, which sometimes are saturated with other vaccine inoculation in the production line, so you don't have capacity to produce them. But the good news is they are already ready, and they would be coming out very soon in 2022. And regulatory bodies have offered a accelerated pathway for the vaccine manufacturers who have got platform technology, who have already successfully developed a vaccine, and those vaccines have got safety data available. So they will get some exemptions from regulatory package, so they don't have to repeat all the trials again, because they're just revising the vaccine with a modified antigen in there. But there would be some safety studies still required, but not everything they needed to do for the first vaccine. So it will be coming out very soon in 2022.
If I could just ask one other question, because I see a lot of fetal patients and a lot of girls, young girls, the fear of this infertility issue. Do you know of a study, because I had a nurse today who works in ICU, got her vaccine 2 months before she got pregnant, and here she is pregnant. Is there someone going to do a study on women who've been vaccinated to assess what is their infertility rate? And if it can be done properly, because I think a lot of parents are going to be scared of their young daughters, or possibly their sons too. But is there anyone looking at this in any manner to help calm the fears of the infertility question?
It's a very important question, but very difficult to answer because the data is very limited and the response varies from one vaccine formulation to other vaccine formulation. There has been a lot of cases reported for disturbed menstrual bleeding in young women, particularly bleeding frequently, bleeding before their period or heavy period, or even postmenopausal bleeding. And what we are trying to do is look at the causal relationship as to, are these specific to the vector vaccines? Is it the adenovector which is causing this? Is it related to thrombocytopenia or ITP, which is causing more bleeding events? Or it's something to do with the other systems in the uterus. So there are certain research groups in the UK which are looking at long COVID, and long COVID also have got this menstrual disturbances issues in the patients. So the antigen is same, probably is the spike proteins and some epitopes on the spike proteins, which might be triggering, maybe activating macrophages and causing this cytokine release syndrome or a hyperinflammatory stage in that area. So long COVID clinics are looking at it, and we will get some clues, and those clues would be then correlated with vaccine antigens, and the revised antigens would overcome that problem hopefully in future. But currently we don't have a solid answer, and the effect varies so much from vaccine formulation to other formulation that it would be wrong to generalize it to all vaccine products.
So we have our chief of pediatric, Peter Azapadi. He does his clinics with the developmental pediatrics. We have Dipali Mankat. And I myself think that, is there any, generally we can say that the COVID vaccines has effect which has increased or enhanced the developmental issues in the kids, or which has like brought it up or bring it on, those kind of things in our children with some behavioral issue, children with some language issue. Has it made it worse? I mean, I would like if Peter can ask something from our keynote speaker. And my question is the same too.
Is that question for me to answer?
Yes. Yes,
Oh,
I was thinking
so,
that if Peter Azapadi has anything along with this comment and question, so he can say it, so you can answer it together. If not, then please go ahead and answer it. Yeah.
Well, I think it's a complex situation. If you look at the virus, there has been some mental health issues in the society during COVID-19, and lots of psychiatrists and scientists in the neurology are trying to look at, is it because of the lockdowns? Is it because of the antisocial behavior? Or is it because of the actual virus causing some neurological issues? And there's a mix of all those. Particularly when you talk about kids, when we look at natural infection, this is a respiratory virus. This is not a blood-borne disease which goes into systemic circulation straight away. So respiratory viruses goes around different barriers and layers of immune defense before they reach to the systemic circulation, cause myocarditis, cardiomegaly, and lots of other systemic inflammatory disorders like MIS-like symptoms. So the advantage is that a lot of healthy population would not let the virus go to that stage, which is why the mortality and disease severity is very low in the age group, and age is the single most predictor for the worst outcomes of the disease. So chances are when the kids get the virus, it goes to the mucosal epithelium, the virus grows in the nasopharynx, and this is the time where body try to fight it off before it reaches to the systemic circulation. So majority of children would not have that, but if the antigens on the virus has got epitopes which we didn't silence, or we didn't know that they are contributing to pathogenesis, and they are part of the vaccine, then vaccines are injectable products. So they are breaching all the barriers and going into the circulation in that way. So there is a correlation there, but it's very difficult to say scientifically because we're still learning about the pathogenesis of the virus. We are still learning day by day about how virus is causing all these destructions in the body, which part of the spike proteins are mediating those responses. And then with time, vaccine revisions will only improve safety because we would know more about the antigen. We would keep modifying the antigen, keep improving the safety profile. So the idea is to keep the antigenicity, but then reduce the pathogenicity on the spike protein. So there is definitely an epitope which causes macrophage activation and increases a whole cascade of cytokine release, which then are pro-inflammatory and causes all sorts of problems.
Thank you. I can see a question you can, Hubert, you can ask from the participants.
I think we're done here for time. If we're going to move on, or do you think we should try to go one more question?
Just one more question. I think Naveen has asked, is saying, does the mRNA vaccines interfere with TNF and therefore the effects of monoclonal antibodies? For example, UC versus Crohn's, ulcerative colitis versus Crohn's. For you, Hamid, to answer.
Yep, I'm sorry, could you repeat the question?
He's asking, does the mRNA vaccine interfere with the TNF and therefore the effects of monoclonal antibody, for example, ulcerative colitis and Crohn's?
It depends. Yeah, it depends what monoclonal antibodies you are looking at. So if you're talking about B lymphocytes antibodies, for example, rituximab, then obviously there will be a direct interaction because B lymphocyte antibodies will reduce the number of the lymphocyte counts. Then you would not have active antibody producing cells. So there is an interaction which people are looking at. And currently there is some clinical trials in UC, Crohn's, and in some other rheumatology clinics where patients are being given same antibodies for other conditions, similar conditions. And they're trying to look at if the pharmacodynamic response of antibody monoclonals is six months or 6 weeks in some cases, then how you time the dose and how much delay you would need for the antibodies to be given after the vaccination. But if they're being given at the same time, then definitely there is an interaction being reported in some clinical studies. So some clinicians are suggesting that those antibodies are delayed. So again, 21 days post-immunization. So the vaccine has been cleared off, and then you have those monoclonals. Otherwise, if you have inhibited CD20, for example, then a CD20 inhibitor's lymphocytes would have a knock-on effect on the vaccine in induced immunity.
Thank you.
So I think we're going to end that there. We do have
Yes.
a little bit of break, although it's shorter right now.
Yeah.
I'm personally going to thank, and on behalf of everybody, I'll thank Dr. Marchand for participating again tonight. That was an amazing talk. It's one of those talks where, you know, you wish you had an extra hour and we can kind of keep talking forever and ever, and then everybody will have all sorts of questions. So really engaging, and we really appreciate that. If you have time, there are some questions in the chat. They would appreciate it. I'm sure some quick answers if you have a minute there. Aside from that, we are going to take a break. I think we're all back very quickly, actually. It's 6:55, which is just like in 5 minutes. But if you guys can take a little bite, get a drink, come back quickly, and then we'll go into our second half of the sessions, which are still just as invigorating and as interesting. So thank you very much. I hope to see you guys all very soon.
Thank you very much. We'd like to take this opportunity to thank all the participants and particularly the Paediatric Network to invite me over to present on this forum. So thank you very much, all of you.
We're just a little bit behind, so I'll be quick about this, but I don't think any introductions are really necessary for Dr. Hamid. I mean, he's been a great asset to our program and to the Scarborough Health Network. I will briefly say, though, that so Dr. Hamid, as you all know, is the conference director of the Paediatric Pearls Conference. Today, he is also an assistant professor in the Department of Pediatrics at the University of Toronto. Dr. Hamid is a general consultant pediatrician with a special interest in emergency medicine and global health at the Scarborough Health Network. He has worked in the Hospital for Sick Children in Toronto, where he completed a fellowship in pediatric emergency medicine and general pediatric medicine. After completing his MBBS in 1992 with Dow University of Health Sciences in Karachi, Pakistan, Dr. Hamid moved to Europe in 1995 and worked in Ireland and England. He completed his 5-year pediatric residency in England and a fellowship in neonatal intensive care unit care at St. Mary's Hospital, London, United Kingdom. In his spare time, he enjoys traveling and is involved in hospital fundraising. Thank you very much. Please welcome for us all together, Dr. Hamid.
Thank you, Hubert, for this so generous introduction. I have noticed that we have talked a lot about the COVID and COVID-related illnesses. I can take our audience or our participants a little away, and this, I think it will be a little bit mind-boggling, or I call it Paediatric Pearls, some articles which I thought had some relevancy in our practice and see how we can see. And obviously, I'm just going to give some highlights about this, and then the article links are there, people can read about it. So I have no conflict of interest, and I'm going to talk 3 of them and then other highlights as well. So the first one I picked is called long-term complication in youth due to type 2 diabetes. This paper, which was published in New England Journal of Medicine in July 2021, there has been a lot of talk regarding the complications and its consequences of having type 2 diabetes, especially in children. We didn't have the solid data where we can say, okay, what percentage? So this study has shown and had shed some light on it. So if you look at it, the background, as I mentioned, is regarding the occurrence of related complication as these youths transition to adulthood. And they have done in the period from 2002 to 2012, the incidence of type 2 diabetes, which I've mentioned that it has also increased by 4.8% each year. So objective was assess cumulative incidence of diabetes related complications and life-threatening and organ damage in individuals diagnosed with type 2 diabetes. So the areas to look for, it's observational follow-up study conducted in 2 phases, phase 1, March 2011 to February 2014, and phase 2, March 2014 to January 2020. And it has 518 participants transitioned to full observation. Medical management was provided by the participants' healthcare providers. And the exclusion criteria were the participants who have some positive genetic results from MODY. So the areas they have looked at, if you look at the hypertension, dyslipidemia, kidney disease, nerve disease, eye disease, and cardiovascular diseases. So if you see that they have some criteria and the definition about this, so based on that, they have done this study. It has shown that the minimal adjusted model for the accumulation of the microvascular complications. And if I say, I'm just getting a little bar on front of me. So you can look at the people they have targeted on non-Hispanic, Black and Hispanic, and then others, which has shown here that how they have the odds ratio and the confidence interval, which has had no significant value for this. So, sorry, just. Sorry, this is just something came up on the front of the screen. Okay, thanks. Thank you. Thank you. So if you look at the odd ratios here and the confidence interval, there is a significant values here in terms of the complications. And if you look at the adjusted model, and especially the treatment versus metformin one in this group, you can see there's not much of a confidence interval difference. In the model of glycosylated hemoglobin level per each increase, it's showing that it is between 1 point. So this is a significant area. And then these are the other, which is looking at the glycosylated hemoglobin levels. If you look at it, it is starting and going up, rising up, and it has gone up within somewhere between 13 to 15 years of life. And same the distribution here on this one. And if you look at the hypertension, kidney diseases, dyslipidemia, nerve diseases, they are all up in the incidence. And based on these, they have the results which they have with the participants in it. It shows clearly that there are 270 out of 677 participants, which is like a 40% had no complication, but 31% had one complication, 21% had two complications, and 7.1% had three complications or more. The complication I just mentioned in my previous slide. And average time of diagnosis to complication development was 13.3 years. If you see that how long it takes our adults to develop some complication, I think it is 20 plus years. So 17 serious cardiovascular events noted in this trial, like 4 of them got myocardial infarction, 6 congestive heart failure diagnosis, 4 stroke-related events. So risk factors for the development of complication included minority race or ethnic group, hyperglycemia, hypertension, and dyslipidemia. Having said that, the discussion was, again, I mentioned the type 1 diabetes takes 32% in 25 years after diagnosis. Type 2 adult onset diabetes, 55% in 25 years after diagnosis. And type 2 childhood onset diabetes, 54% in 13 years after diagnosis. So these, you can see that while you are even in early 20s or late teens, you end up having the complication of your major system. So the factors for high incidence of complication is that they have showing the extreme metabolic phenotype, severe insulin resistance, and suboptimal response to medical therapy, and the challenges in the adherence to the therapy. So the conclusion here for this, the study show a high burden of complications in youth onset type 2 diabetes, a regular screening for complication, and aggressive glycemic management recommended in this population. As a general pediatrician or family physician, it gives us a kind of caution that we should be very careful about managing these patients. So my next article, which I picked, is tympanostomy tubes or medical management for recurrent acute otitis media. It's another very common topic, and which is being usually these acute otitis media, mostly seen by either family physicians or seen by general pediatrician. And obviously, if there is a complication or if there is a recurrence or increased frequency, we definitely get help from our ENT specialist. So it published again in New England Journal on May 2021, and it has basically looked at the frequency of otitis media over a 2 years period. So they basically wanted to see what is the principal indication for the tympanostomy tube placement. And for those, just for myself as well, to remind myself the definition of it, it's recurrent otitis media defined as 3 episodes in 6 months and 4 episodes in 12 months, at least 1 episode within the preceding 6-month period. So the previous trials of tympanostomy tube placement for recurrent acute otitis media gave mixed results in either small sample size or uncertain validity of diagnosis of acute otitis media, short follow-up periods, and substantial attrition of participants. So the study objective, as I mentioned, they want to compare the tube placement with medical management in children and the rate of recurrence of acute otitis media during a 2-year period. So the study design, it was double-blinded, randomized controlled trial. Population was children aged 6 months to 35 months who had at least 3 episodes of acute otitis media within 6 months, or at least 4 episodes within 12 months, with at least 1 episode within the preceding 6 months. So intervention was tympanostomy tube placement, and they compare with the medical management. And this is like a PICO question, like population intervention comparison, and the outcome was mean yearly number of episodes of acute otitis media per child during a 2-year period. So interestingly, if you look at the outcome, it's clearly mentioned here that the children who is having year 1 and year 2, there's always a delay in having a otitis media after the tube placement as compared to the medical management in the first year. But if you see it over a period of 2 years, there is no significant delay. If you look at the estimated group difference of confidence interval, here you can see it's around 0.8 to 1.1, p-value of 0.66. And another thing they have looked at is the estimate of the severity of the episodes. Is how severe the episodes being has been reported once you have, if you compare between these two. So they have mentioned, again, there is not a significant change, especially in the severe between non-severe. But the treatment failure, if you look at it, there is some variation here, and it has a failure reporting more. And even I've noticed when I was reading the article that there are a lot of parents, even it's a double blind, they have chose to one therapy to the another. Mostly they went from the medical management to the tube placement. One thing was very clearly noted that if the autoria, the duration of the autoria is more in the tube placement than compared to the medical management. And if you look, yeah, this is the one I was trying to highlight it. So if you see is in the tube group, 73, and in the non-medical management group is only 28. So there is you can see the risk ratio and confidence is 1.9 to 3.4. So if you look at the year-by-year ratio, the tympanostomy has 1.48 and the medical management is 1.58, which is a p-value of 0.66. So what they claim is that more time to a first recurrence of acute otitis media and less treatment failure in tympanostomy group, but overall less cumulative duration of autoria. So in terms of conclusion, we say that receipt of we say that among children between 6 months to 3 years, and the recurrent acute otitis media, the rate of episodes of acute otitis media during an overall 2 years of period was not significantly lower with tympanostomy tube placement than with the medical management. So we as a pediatrician or we as a family physician see that should we really need to put the child through suffering of going through the procedure or not? Again, it's difficult to say in a blanket form. It obviously is different with the case by case. The last one, which is very interesting, I would like to have, I know that I do not have much time left. The last one, which is antibiotic use and outcomes in children in emergency department with the suspected community pneumonia. It is also published in Paediatrics, just April 2020, although it's an interesting article, perhaps many of you have already gone through. And it has the background that either you give the community-acquired pneumonia a special place when they come to you and it's a sign and symptoms are suggestive of some form of pneumonia, either family physician or from the emerge, we do send them home if they are not in acute distress with some prescription. So the study objective, they evaluated that thing as compared to a close follow-up, like to investigate the association between antibiotic prescription and the treatment failure in children with suspected community-acquired pneumonia who are discharged from the hospital emergency department. So again, study design between 3 months to 18 years, exposure, antibiotic prescription or receipt, or the receipt of the antibiotics, comparison supportive care without antibiotic prescription or supportive care with follow-up, close follow-up in the clinic. So the outcome was treatment failure. And the treatment failure they have defined either being discharged from emergency department or return visit with the antibiotic initiation or chain or antibiotic chain within 7 to 15 days from the ED. Again, they have looked at it and they have found no obvious confidence interval and in between these two groups. And if you look at the child which has been have some median for usual activity or their quality of life has also made some changes on that. Again, there was no statistical significance difference was found between receipt of antibiotic prescription after ED discharge based on the phone follow-up. They were trying to look for what are the symptoms. So conclusion, no association was found between receipt of antibiotic prescription and treatment failure. Antibiotic prescription was not associated with a difference in quality of life measures or parent-reported symptoms after discharge. And pneumonia in younger children more likely due to viral cause. As mentioned in the paper, only 15% had bacterial pathogen as compared to 73% which has viral pathogen. So this study suggests that it may be safe to manage outpatient children with a suspected pneumonia without antibiotics. That's just a thought. I have just few more highlights of the papers here. I will not be talking in detail, but one of them is the incident and nature of adverse reaction to antibiotics used in endocarditis. And again, they actually, it's a guideline came this year, although the study was old, but the guideline came this year instead of clindamycin. They are, instead of the clindamycin, they are saying to use the alternative medication. And I would go with the first one here. It's another a little early onset sepsis cases. It's a calculated versus individual patient. So they have done a meta-analysis and they have found that it is very effective, but it's not very safe to just rely on that. Perhaps I think this tool can be more used in our non-clinical, I mean, other than the doctors, maybe our nurses or other paramedical staff to use this and give us a heads up or alarm our healthcare facility or healthcare team if the score is sitting on that.
So Hamid, I'm just going to interrupt you there.
Yeah.
We're a little bit over time, so I think we're going to have time for just one question, if it's okay. And then I'll go ahead and introduce our next speaker. Did
Sure.
you need to summarize or finish up any?
I just 30 seconds. I'm almost done. I just want to quickly show these articles which has some interest. Another one with the phototherapy after discharge, and again it has been talked in detail by Dr. Bolio, multisystemic inflammatory syndrome in children, initial therapy and outcomes, and so I think that was the one I just wanted to mention. And also, if you can look at the effects of probiotics in preterm infants, a network of meta-analysis in which the answer is you need to have prebiotic and as well as probiotic for the premature children to get the best benefit. And the last one is I just mentioned about the endocarditis one, and they recommend to avoid clindamycin because there is some death related to that. Thank you.
Thank you, Dr. Hamid. Thank you for once again organizing this conference today, which was well organized and it's been really educational. I'll keep my question brief and maybe we'll just move on after my question in the interest of time. So I guess my thought with the community-acquired pneumonia article, which was very interesting. I know statistically speaking, probably the vast majority of these are viral infections, which was suggested in the article. But did they suggest any distinguishing features which would guide our therapeutic intervention or stay of intervention?
Well, they have looked at all the sign and symptom, but at the same time, some of them look for the X-rays as well. So the X-ray finding doesn't have any collapse consolidation picture, or child is not acutely distressed, then you can safely monitor. Because if you're already thinking to send the child home with an oral antibiotic, so they are thinking, why not just monitor them and in a close follow-up. So they have looked at those, and they have lots of, they have used the parameters over there for diagnose that. So based on that, it was very interesting for me, and I read, and I think it's something we can think and read more in details to make our own judgment.
Okay, thank you very much. Okay, so we're going to move on to our next speaker. We just have a few more. I think it's an interesting segue when we go from some of the medical aspects of COVID vaccinations and how the pandemic has affected children over the past year, and we move into some of the broader picture of how the pandemic has affected children as a whole. So I'm going to introduce our next speaker is Dr. Ruben Gagarin. He's a comprehensive child and adolescent psychiatrist at the Scarborough Health Network. As a psychiatry inpatient and consult liaison, he manages both children and adolescents with a full range of mental health and developmental conditions, including autism spectrum disorder, mood and anxiety disorders, and psychotic disorders as a part of a multidisciplinary first episode psychosis program. Dr. Gagarin received his medical degree from Bashkir State Medical University in Russia, completed his psychiatry residency and child psychiatry residency fellowship at the State University of New York at Buffalo. Dr. Gagarin is also the head of the Child and Adolescent Psychiatry Program at the Scarborough Health Network, where he leads a team of 7 physicians working in multidisciplinary environment with social workers and registered nurses. Thank you for attending our conference tonight, and we welcome your speech tonight.
Well, thank you very much, Hubert, for a kind introduction. It's everybody these days seems to be having mental health issues. So I guess that only makes sense to include the psychiatrist in this conference. All right, so let me just see. So share the screen. I was a little bit slow. I was like enjoying your introduction. So how about? I think this should work. So is it working?
Yes, it is working.
Okay, perfect. All right. Well, hello everyone. So I'm happy to be a part of this conference. So I try to keep my presentation quite brief, and we have a good chunk of time for the questions. And I encourage you to ask questions, whatever you find burning. So it not necessarily has to be related to the presentation today. So just to give you a little bit of background. So as you know, during the pandemic, the cases of eating disorders, anorexia nervosa, as probably many other mental health conditions, increased dramatically. And considering the isolation, many of patients with anorexia nervosa, they stayed home during lockdowns, and maybe that is one of the reasons why we see more and more hospitalizations for medically unstable anorexia nervosa. So because the patients have less eyes on them, so and as a result, they basically end up in a hospital. So the rates of the hospitalizations doubled in according to some of the studies. And as a result, what we see at SHN is admissions for malnutrition due to eating disorders to pediatric unit. We unfortunately do not yet have a fully developed eating disorder program, and we have to just make do with what we have. So we cannot turn away patients who are medically unstable, and we have to support them one way or another. I became part of this team, and we kind of have this ad hoc sort of assembled team that kind of trying to help these families to get through the crisis. But yet again, if you have questions regarding anything else, in my experience, I work as an outpatient, inpatient, crisis, consult liaison, day hospital. I should be able to answer your questions. So let's dive into it. So anorexia nervosa and comorbidity management. So as a psychiatrist, oftentimes we get called for help for eating disorders when our patients need management of comorbidities, not so much the eating disorder per se. I'll get to that a little bit later. So most common comorbidities, at least according to this study of inpatient female patients, 97% have at least one psychiatric comorbidity. So you can see here it's just almost 100%. Almost everyone with eating disorders has another diagnosable psychiatric comorbidity. 94% have mood disorders, mainly major depressive disorder, and 56% have anxiety disorders, let alone that eating disorder naturally comes with a lot of anxiety related to refeeding and regaining weight. 22% have substance use disorder and more with bulimia. So 20% have PTSD. Interestingly, in my experience, a lot of patients with eating disorders have trauma, and many of them can be diagnosed with personality disorders, which also a lot of the time is a result of trauma. And PTSD, though, cannot be always diagnosed based on the set of symptoms identified by DSM. So I put an asterisk for two personality disorders because it's important to mention, but in this particular study, they only looked at so-called Axis 1 diagnosis, which is pretty much everything but personality disorders. So what treatment challenges come with that? So the malnutrition prevents recovery. This is a big one. So if you think about anorexia or any other state of a person being malnourished, they just essentially don't have enough nutrients in their body to make enough proteins or make enough any kind of chemicals. So their body goes into starvation mode, trying to preserve every single bit of energy to survive. When you look at something like antidepressants, a lot of the time we rely on so-called serotonin reuptake inhibition. But to inhibit reuptake of serotonin, you need to have a serotonin to be released before it gets reuptaken back. So therefore, it doesn't matter how much you block the serotonin reuptake if there is no serotonin. So there is nothing to be blocked. And unfortunately, in our anorexics, what happens is that they just don't have enough nutrients, to make many chemicals, including serotonin or dopamine, etc. Psychotherapy is a treatment of choice. So, and the biggest challenge that most of our patients, they're resistant to the change. So they realize that if they get better, they have to regain weight. And the essence of the anorexia nervosa is a fear of regaining weight. So they do not engage in psychotherapy. So that is very unfortunate because, again, if the medications don't work and they don't engage in psychotherapy, we don't really have a lot of options, which is sad. So family dynamics, again, in our program, we can take excellent, as a matter of fact, care of the medical conditions, refeeding. We have a great team, including a dietitian. However, we do not have, unfortunately, family therapy. And in our current setting in the hospital, a lot of the time, family continuously gets involved, continues to be involved with the patients. But we know that part of the eating disorder is family dynamics. And as a matter of fact, the psychotherapy that I mentioned in the previous point is a lot of the time focused on the family dynamics and family therapy. So another point is that food refusal does not equal anorexia nervosa. So throughout my practice, I have seen patients who were taught or educated about anorexia nervosa instead. So they were told that they have an eating disorder, where in fact they didn't really. Sometimes what we see is somebody with autism spectrum disorder, for example, who are extremely picky eaters. So they only eat pasta, for example. So, and that's it. So of course and then they may not have a lot of appetite. So they end up, or maybe they're sensitive to the texture of the food. So they end up being malnourished, but they don't really try to lose weight per se. So one of the patients who I saw in the inpatient unit lost a lot of weight, but had actually severe anxiety disorder. But interestingly enough, as that person was trying to live a healthier life and exercise more and be more fit, they found themselves in a malnourished state, which affected their way of thinking, their ability to analyze their current state, and they end up kind of spinning in sort of vicious cycle, and it got to the point that they needed to be admitted for medical reasons. And of course, what also happens, unfortunately, is that even among medical professionals, the stigma of mental illness is rampant. And sometimes what happens is that once a person suspects a patient having mental health condition, a lot of the time medical conditions may be overlooked. And it is important to keep in mind that many of other medical conditions may cause malnutrition, and especially if it coincides with some problematic family dynamics or anxiety, it may be overlooked or missed. However, when they get into eating disorder program or mental health program, we have less resources to investigate. So just keep that in mind when it comes to your patients. So treatment strategies. It is important to understand your patient. To be able to use motivational interviewing. On Medscape website and some other websites, there are a lot of resources, excellent summaries how to appropriately use motivational interviewing that can be used not only for mental health issues, but also for substance use, smoking, cessation, and medication non-compliance, etc. So the essence of motivational interviewing is to help the patient to move through the resistance and understand that their current choices do not necessarily reflect who they are. It's not as simple with eating disorders because very recently one of recent patients who we had to deal with, she had a dream to become an actress. However, when I asked her, would she rather be an actress but eat well so she can perform well on stage, or remain thin and continue to starve herself? Unfortunately, she said that her really main goal would be to stay thin, even if it means to sacrifice her life goals. It is important to identify those life goals. Even in case of my patient, on the surface, she may say that, but from one appointment to the next, I may be able to identify other family goals that may be more important to her and be able to move her along. Aligning yourself with the patient's goals. So that is kind of goes into more a power struggle. So what I notice is that, not just me, so the patients with anorexia, with any kind of eating disorders, especially with anorexia, they strive for control, they strive for power. They do have a lot of power, a lot of willpower. They definitely have more willpower than I do. So I'm having a problem saying no to a cookie. They can starve themselves to death. So like if I start any kind of power struggle with them, then I'm never going to win. I know that. Our strategy, at least in the beginning, is to try to understand the patient and maybe assume that one of their goals is to remain thin, and not to argue about that goal, because all of our relationship then becomes a lot about eating disorder and the weight, whereas it really should be about what their life goals are. Also, it's important to include the family. Because again, they are they may be part of the problem, but they also are a huge part of solution. So, and it is also important not to become sort of a part of the family, but to be a kind of a distant observer, because that role is allows you to make observations, make feedback without getting involved in the family dynamics. So I find that most of our patients with eating disorder, especially with anorexia, they're extremely resourceful. Therefore, it is very important to be transparent when it comes to medication or treatment options, the likelihood of hospitalizations, medication side effects of their condition. So the more open you are and the more your words are cross-checked with their research, then the more trust you gain with the patient. So it's also important to be genuine, and if you find yourself maybe frustrated or helpless dealing with them, it's okay to share those feelings. Again, it's important to keep the boundaries, not to engage and not to become about you. However, if you feel some emotions, they probably see it in your face. So it's okay to share it, especially if you feel if you have a strong urge for that. So it is also important to have regular and possibly frequent appointments with patients with anorexia nervosa, because they may become medically unstable quickly. Their condition needs to be monitored. Plus, it is really very good for the relationship and trust. So, briefly, criteria for involuntary hospitalization. There are more, but these are usually the most common cited. Temperature below 35.5 Celsius, heart rate below 45 beats per minute, or symptomatic postural tachycardia, blood pressure systolic below 90, or orthostatic change over 20, with signs of hypovolemia. Sodium below 130, potassium below 3.2. So these and some other criteria may justify a involuntary hospitalization for medical stabilization. At that point, if person meets this criteria, they are likely not be able to make decisions for themselves. So it becomes an emergency, and even if they refuse to be in a hospital, they still may need to be hospitalized.
Ruben, there's just 1 minute left, if you don't mind.
Okay, so quickly criteria for Form 1. So imminent danger to self and others. And it's important to know that 1/3 of lethality and anorexia associated with suicide. So I'm going to skip that. You probably know the rest. Treatment of comorbidities. So food is a treatment of choice for anorexia nervosa, as I mentioned. So you have to have chemicals to produce serotonin, etc. Benefits of antidepressants are very limited in malnutrition state. When considering medications, you may increase, medications that may increase weight, it's important to discuss it openly with the patient. I noticed that olanzapine, for example, Zyprexa, and quetiapine, those medications can be very helpful for anxiety and sleep when the patients go to bed. Again, antipsychotic medications, they block dopamine. They do not rely on the production of the chemicals per se. However, there is no consistent evidence for the response to these medications. Fluoxetine is the medication that has been studied the most. However, it's quite inconsistent. So psychotherapy becomes a treatment of choice. So it's important to provide patients with community resources. Again, most of the clinics would not accept them if the eating disorder is the main diagnosis. Even if the eating disorder is a substantial part of the patient's condition, the clinics would not, they may not accept that. You may rely on the private therapy. Again, just keep in mind that a lot of the parents, many parents have the benefit through work, so they actually may have access to the psychotherapy privately. So as I mentioned, antidepressants, antipsychotics may be a part of solution. Consider pregabalin. So pregabalin has evidence for anxiety disorders. So it's a mild anti-seizure medication, which may be helpful sometimes if you try it more conventional and you need to kind of try something that's less conventional. So, and lorazepam may be useful to deal with mealtime anxiety. In my experience, there is no much success with that. However, it can be tried in a right individual, it can work. And again, considering that they don't have a lot of chemicals around their brain, so use higher doses for efficacy. For example, for fluoxetine, the best evidence for 60 milligrams a day. So, poll question. What is the best medicine for anorexia nervosa? Oh, here it is. Does anybody care to click? Oh, there is one.
I think people were listening.
Yes, but this is a tricky one. All right. So, okay, well, in interest of time, so most people say fluoxetine, but it's actually frittata. So the food is the best medicine for the eating disorders. So without appropriate nutrition, fluoxetine would be quite useless, unfortunately. All right. So,
all right, so
thank you. So this is our summary. So I don't have to go over this again. So questions?
Thank you very much, Gagarin. That was an amazing talk. I've always found you very helpful with all our difficult patients that we see, and you know, the interventions have been amazing. So I am going to move to the questions because we're a little bit over, so we don't have a huge amount of time. So Sarah Doyle is asking, how do you motivate patients with suspected anorexia but poor insight to get them seen in the eating disorder clinic?
Yeah, that's a challenging one. So basically, what I mentioned on that slide, the best chance you have is to have a best understanding of their values, to understand the patient, what they're striving for. Not just perfectionism, but what are their life goals? Do they want to be an actress? Do they want to be a doctor? Do you want to be a lawyer? Or maybe they want to have a family, and they the more you talk to them about life goals, the easier that is to see what their values are. And if you align yourself with the values, then you can sort of pose this kind of soft confrontation, which is a big part of motivational interviewing. You can say something along the lines that, on one hand, you're planning to have a family and you're planning to have children, but because you're not eating very well, you actually don't even have periods. So it would not be possible if you continue the same way to have the family and children. How do you reconcile those two values? What is more important? How would you like to deal with that? It's important to maybe remain neutral. So because if they feel that you're judging them, they may not necessarily give you the honest answer, but you just kind of remain curious, because it is a curious question. You have a highly functioning intelligent person in front of you, and they sometimes fail to see this obvious disconnect between the two. So look into motivational interviewing. Honestly, that's the best shot.
That's a very interesting topic for sure. I want to take a minute to remind everybody to fill out the feedback form for the Paediatric Pearls Conference. And to get your CME credits, which is 3.5 hours today. It's been a great conference so far. Our next question comes from Dr. K. She says, I have several teens with anorexia nervosa who have persistent orthostatic tachycardia despite weight restoration and return of menses. Some lightheadedness if they get up too fast. Any suggestions? Blood pressures have been stable.
Can you ask Chair to reshare the feedback form?
Pardon me? Oh, yeah, so it's probably not related. Okay, so I think it's actually a question better be asked by a pediatrician or adolescent medicine physician. I'm thinking though that if they have dizziness, it could be hypovolume. So let's say if their blood pressure would probably suffer. So it's to be honest, I don't have the answer to that. Just keep in mind that sometimes the patients with anorexia, they may be deceitful. So then what may happen is that maybe before they come to your office, they may have a few kind of maybe run to your office to maintain their blood pressure pretty high, but there's the signs of hypovolume still may exist. I would say maybe do the full orthostatic hypotension test with like a couple of minutes sitting down, a couple of minutes standing up, and sort of maybe assess if that would show signs of low blood pressure or hypovolume. That could be it. Because another reason why patients sometimes have feeling kind of lightheaded, it could be anxiety. But why would they be anxious about standing up, right? So
can I have a quick question? Another, if you allow me, Hubert, just a quick one. Thank you, Ruben, for a very interesting talk. I have one question. Like, is it easy to work with anorexia nervosa, which has multiple other issues, or just only one issue?
Well, to be honest, in my experience, I have never seen an anorexic person with one issue. So there is always multiple. Even if it's not formally diagnosed, they would have some psychological issues or like family concerns, etc. I think that everybody knows the question. This is one of the most challenging populations that you have ever met. We can have an hour conversation about consent and capacity, for example. It's very, very challenging. Unfortunately, the best shot that they have at recovery is multidisciplinary teams. The Scarborough is covered by North York General Hospital. They have outpatient programs or inpatient as well at Sick Kids and Ontario Shores. However, there are a year or sometimes longer wait lists. And you can imagine that in a teenage person pretty much solidifies in a year or a year and a half. So if anorexia nervosa remains a part of their life for a year and a half while they're waiting for the program to kick in, it's a lot harder for them to recover. The only thing that you can do as in outpatient settings is just monitor their vital signs and hospitalize them when they're unstable. And if they continue to refuse food, that the treatment of choice would be NG tube. But yet again, the response to the NG tube feeding, it's kind of hit and miss, depending how you ask a question and who you ask. Some studies actually show that they're overwhelmingly positive. So recovered anorexics, they actually say, well, I'm glad that somebody took charge and actually put that NG tube because I would never recover without it. But then you ask others and they would say, well, that was useless torture because then the problem never went away and it continues to bother them. So it's just case by case, I suppose.
Okay, I think that's all the time we have for that question period. Thank you very much, Ruben. That was a very helpful talk, and it's so interesting, like the different aspects of how COVID has affected our lives and the lives of all the children we take care of. So thank you very much.
Thank you, everyone.
Okay, so I think our last speaker, we're not sure if she's having. Oh, there she is. There she is. So I think her technical issues are overcome. So I think if you're ready, Trish, give me a thumbs up if you're ready. Yeah, she's ready, great. So I'm going to introduce our last speaker of the evening as a little segue from Dr. Gagarin, who looks at anorexia nervosa from a psychiatric perspective, to Dr. Tulloch. So Dr. Tulloch is our adolescent medicine specialist and assistant professor in the Department of Pediatrics at the University of Toronto. She completed her pediatric residency in Ohio State University and subspecialized residency training in adolescent medicine at the Hospital for Sick Children. She completed a clinical fellowship training in addiction medicine at the Center for Addiction and Mental Health. Dr. Tulloch is a physician at CAMH in addiction medicine in the nicotine dependence clinic. She is an associate staff physician at the Hospital for Sick Children in the Division of Adolescent Medicine and at Centenary Hospital. She's currently the Vice Chair of the Royal College of Physicians and Surgeons of Ontario, area of focus competency in addiction medicine. Her academic focus is in the continuum of care for adolescents and transition age youth, with concurrent substance use, mental health, and co-occurring medical conditions. Please join me in welcoming Dr. Tulloch and inviting her to end our conference today. Thank you very much.
Okay, can you hear me? Is that okay?
Yes, yes, we can hear you.
Great. And I'm just wondering if you can see my slides.
I don't, we can, it doesn't seem in presentation view yet. Maybe that, there you go.
Are you able to see them at this point?
Yes, they look fine.
Okay, great. Okay, thanks. Thank you very much, Dr. Wong, for that introduction. And it's really nice to be here. I'm hoping that I can kind of zip through the slides. I know that we're kind of running out of time, but also hoping to be able to capture and kind of get through a bit of what I would say is another really quite hot topic in line with the conversation that we've been having pertaining to eating disorders. So we'll go ahead. So today we'll be talking about the overdose crisis, more so around adolescence. So more in that context of what ourselves as pediatricians can really be considering when we're thinking about our adolescents who are at risk. I have no conflicts of interest. In terms of the objectives, sorry, at the end of the session, I'm hoping that you'll be able to describe the trends specific to substance-related morbidity and mortality. I'm hoping that at the end, we'll be able to discuss a stepwise approach to the identification of problematic substance use for adolescents who are at risk. And I'm also hoping that we'll be able to describe a targeted assessment for substance use related risks and an approach to treatment based on this assessment, and keeping in mind the developmental trajectory, the developmental perspective, as well as the psychosocial factors. So we'll just start with talking about the substance related mortality and morbidity data that we have to date. Taking a step back pre-pandemic, what we were seeing before the pandemic was an uptick in terms of the number of overdoses related specifically to opioids. And this is our national data captured in 2017. And what we can see here is that the rate is per 100,000 in terms of population. And the numbers which are in the gray circles are the number of deaths per year. And this was for 2017 data published through the Public Health Agency of Canada. So you can see that Ontario is just coming second to British Columbia. In terms of youth-specific data, in British Columbia, they did look at adolescents ages 10 to 18 over the course of about a decade, and they've captured youth illicit substance-related deaths. And you can see an uptick starting at about 2016, and then a bit of a decline in 2017. And data that we are aware of is that there certainly is an increase that started at around 2019, which we can see if we look at our Ontario data. This is specific to youth ages 15 to 24. So this is the table that's, or the graph that is on your left to my right. And these are the cases of opioid-related mortalities captured between years 2003 and to 2019. So again, a very similar upward trend in terms of the numbers of opioid-related mortalities. So the Canadian Institute for Health, they did look at data specific to hospitalizations. And I think this is quite relevant for all of us who care for adolescents, in that they found over the course of a year, so 2017 to 2018, that there was a significant number of adolescents who were hospitalized secondary to substance-related concerns. So in fact, over 23,000 hospital stays were for harms secondary to substance use among youth ages 10 to 24, and this is national data. So this is equivalent to about 65 admissions per day across Canada. And what was quite significant is almost 20% of these youth were hospitalized for more than once. So more than one hospitalization over the course of that year. So when we think about risk, again, this is certainly a way that we would be thinking about a metric to capture those adolescents who are at increased risks for morbidity and mortalities secondary to substance use. Other data that has been captured related to substance use related harms, injury, the CPS surveillance study looking at vaping related injury and illnesses among Canadian children and adolescents did look at a one-time survey among our pediatric providers in 2019, and they looked at 88, or they captured 88 cases of severe vaping related injuries, where the most common reason for vaping related injuries were respiratory distress, and about 15% were vaping related ingestions. So when we think about the trends, or we try to at least capture or understand what the trends are, with respect to our Canadian cohort, we look at youth ages 15 to 19, and we ask about over the past month, whether an adolescent or youth have engaged in either e-cigarette use or tobacco cigarette use. What we've captured over the course of 2 decades is a decrease in that number with respect to the cigarette smoking that's been endorsed, but an increase in the e-cigarette use, which is probably not much surprise. And again, a similar plateau, which we'll talk about in a moment, with respect to that year around the onset or around the beginning of the pandemic between 2019 and 2020. So similar to our Canadian data, the US data here does show a similar trend where there's an increase in terms of the proportion of adolescents, these are high school students, reporting vaping nicotine, and then a bit of what has been noted as a bit of a plateau between 2019 and 2020. What's important to know, though, is that the most recent data that's been captured and compared in terms of Canadian versus the US cohort is that we're actually seeing that the Canadian cohort of adolescents and youth is surpassing that of the US. And we're seeing, again, another uptick in terms of vaping, a trend in terms of the number of adolescents endorsing vaping nicotine. So I'm just going to go ahead with the question, just to see just everyone's knowledge in terms of the common substances reported among our Ontario high school students, and this is from the data in 2019. So what are the 3 most common substances reported among Ontario high school students in 2019? And so the first option would be cannabis, alcohol, and opioids. Second option, cannabis, alcohol, and e-cigarettes. The third being alcohol, high caffeine energy drinks and cannabis. And then the fourth being alcohol, high caffeine energy drinks and e-cigarettes. Should I go ahead with the poll or for Dr. Wang?
Okay.
I don't know if I can, oh, here we go. Okay, sorry. Yeah, I just saw it. Okay, so we have, I'm not sure if everyone's able to see what the outcome is, but it looks like it's pretty split among those who've looked at cannabis, alcohol, e-cigarettes versus alcohol, high caffeine energy drinks, and cannabis. But in fact, I can share those results. I lost my ability to go next. Okay, sorry. So in fact, it's actually alcohol, high caffeine energy drinks, and e-cigarettes. And so this is the OSDIS data. So the orange bar is the 2019 data, and you can see that alcohol, caffeinated energy drinks, and e-cigarettes are the top 3 substances reported, but really close right by is cannabis, so it's still up there. But important for us to understand just in terms of our kind of local trends that we're seeing as we think about what we'll be seeing in our clinical settings. This is just a quick graphic just to consider the amount of our dollars that are spent. And in fact, this is 2014 data, so I can only imagine what the numbers look like to date. But 38 billion when we think about substance use costs for Canadians in 2014, with alcohol and tobacco being about 70% of the total costs. So just to quickly kind of move forward with an approach. So when we're thinking about our clinical approach to substance use in terms of assessments, really what we're hoping to do is identify as quickly as we can in terms of the primary substances that are reported, and then consider what the risks are in order to align our intervention. So we'll have 2 brief cases to walk through this approach. So first we have Tyler, who's a 13-year-old male who's admitted to the ICU following loss of consciousness secondary to an opioid overdose. And the comprehensive drug screen did reveal fentanyl on presentation. He has a past medical history of cannabis use, e-cigarette use, alcohol. He has a additional history of ADHD, oppositional defiant disorder, and he also has some concerns in terms of legal charges. He's currently taking or has been prescribed fluoxetine 20 milligrams daily. So Tyler now is presenting for the second time to the hospital with this is his second overdose. And he is being kind of prepped for discharge, and he's scheduled for a follow-up in your clinic. So that's Tyler. And now we have Kayla. Kayla is a 15-year-old female, and she's been admitted to the hospital with a previous history of asthma. She was also admitted to the ICU. And prior to the ICU, she presented to the emergency department 3 times over the course of 2 months. During this admission, she states confidentially that she has been vaping high concentration of nicotine daily, but her parents were unaware. She's going to be returning for follow-up in your clinic as well. And when she does return to the clinic, she was reporting ongoing vaping of nicotine. She has a past medical history of anxiety and depression. When you ask about her medication, she's uncertain about which medications she has prescribed. So the first step is to focus on identifying the primary substances. So in Tyler's case, we could probably safely say that we are focused on opioid use, and for Kayla, it would be vaping nicotine. In terms of our HEADS assessment, which hopefully many are aware of the approach that's taken with respect to acquiring a psychosocial history. And when we talk about substances, if we can hone in on, again, the primary substance and getting a little bit more of the details around the use of that substance. But most importantly, when we're thinking about the next step, we would really need to know when was the last time the substance was used. We'd like to then move forward and expand that assessment. And one of the probably more straightforward approaches is to incorporate the CRAFT, which is a screening tool that is incorporated here in order to establish whether there's problematic use in terms of severity. So in the case with Tyler and Kayla, we would be able to safely say, in terms of the first 3 questions, that over the past 12 months, both would endorse at least one substance. And therefore, for part A, when it asks whether there is a substance that has been used over the 12 months, the answer here would be yes. So this is just a brief summary of the HEADS assessment for both Tyler and Kayla. Really just to highlight for Tyler that he is endorsing that his friends are also using substances. In addition to that, he is using cannabis frequently and reporting binge drinking, and then also vaping nicotine, in addition to the opioid use. And for Kayla, she also reports that her close friends are using substances, and she's also using cannabis, and we've already discussed the use of the vaping nicotine. So the CRAFT does this, and this is the newer version of the CRAFT 2.1, which you can find in the Canadian Pediatric Society's statements. They've incorporated this in terms of the tools that are available. What's important to note is that even if an adolescent reports no use, so this is where this has been revised, we would still go ahead and ask the following questions related to whether they've been driving either with someone who has been using, or if they themselves have been high and driven a vehicle. And we'd also ask about whether they've been using substances to relax, and we'd ask about whether they've been using alone. So it's really important to remember that this is a revision. Before this version, we were only going ahead with this part B if there was a report of substance use in part A. So
Trish, I'm going to have to tell you we're near the end there. Trish, we don't. We maybe just finish up in a minute. Yeah,
sure. Yeah. Okay, so what I'll do then is I'll just move forward to talking about the problematic use quickly, just to make sure that we can capture where we are in terms of the next steps and as I talked about, the stepwise approach. So I had the first pearl just to make sure that we were capturing the primary substance use and expanding an assessment beyond HEADS, and then describing a targeted assessment for acute substance use related risks. So this is the stepwise approach. And then if the CRAFT is greater than 2, then it's problematic use. I'll just move ahead then instead of talking about the details in terms of the risk here. So in terms of the assessment with respect to opioids, we just want to make sure we're aware of withdrawal symptoms. And this is just the list of withdrawal symptoms that we should be thinking about. And then when we think about Kayla in terms of her use of nicotine, we would use a dependence scale in terms of looking at whether there is a dependence. And then we would also think about some of the withdrawal symptoms that she may have. And these are the common symptoms reported. And so the second pearl is to make sure that you are clear about the risks of withdrawal, the possibility of intoxication, the potential of substance use related harms. And then just coming to the end of the steps here, just to remember that once we know when the last use of a substance is been endorsed, then at that point in time we'd be aware as to whether or not the adolescent would be at risk for withdrawal. And why this is important in your clinical setting is that you can actually at this point consider pharmacotherapy, at least as a first line in terms of an intervention. And for Kayla, this would be the incorporation of nicotine replacement therapy. And for Tyler, it would be likely to have him engage with services with addiction medicine, so the rapid access clinics or breakaway addictions, or some of the community providers who would be able to provide opioid agonist therapy. So lastly, just in terms of treatment, the last phase would just be to make sure that we look at the harms and think about risk reduction, think about pharmacotherapy, as I've just mentioned, really consider psychological supports in terms of some of the supports that we can add as an adjunct for both the patient and for parents and or caregivers. If there's a requirement for stabilization, there may be an approach that could be taken where an adolescent could be admitted involuntarily. And this would really require a team effort in order to consider stabilization. But that's certainly, this is a discussion that we're really moving forward with, and British Columbia has really spearheaded a lot of this work. We've already talked about the risks in terms of driving, and that comes up with the CRAFT assessment. We've discussed pharmacotherapy, so here are the details here. And then lastly, here are the resources that you can consider. And I would actually just point to specifically Breakaway Addictions, which is a resource and an organization that provides treatment and a whole host of supports for both the patients and their family members. And they can actually meet a lot of adolescents at their home or even at their schools. Really, the main point of this service is that they're really meant to be a service that meets the adolescents where they are. And I've also listed here the Toronto Opioid Support Team, which has a very similar approach. Okay. And so just, I guess, briefly, really in summary, just highlighting the main 3 points: identify that primary substance or primary substances, and then expand that assessment beyond shades to acquire more information in terms of whether this is the adolescent is engaged in problematic use. Target your assessment to the extent where you can assess whether there's risk associated with either the probability of intoxication or withdrawal, and then address any of the harms and incorporate a multi-pronged treatment plan.
Thank you. Thank you very much, Trish. I think that was a wonderful talk, and we're getting definitely a lot of questions. So I think it's always a very stimulating conversation when you talk to them about teenagers and youth.
Yeah.
So just before we get into some of those questions, I want to take a break to just kind of remind people to fill out the survey form as part of the feedback, so that you can also claim your CME credits. Everybody, the link is in the chat right now. I also want to take a moment to actually thank some of the people who have been helping us from the administrative side of the perspective, and I'll have to apologize if I'm not saying their names right. It's Lachman and Achaya, and they have been really great in actually making sure that this conference works and has gone smoothly, because we as medical professionals have very little insight, I think, on how to use Zoom and all its functionality, but they have done a great job in making sure that this has worked. So I think, big round of applause for them. So I think for the last number of questions, we are getting a few, so I'll start off with one of them. The question comes from Navin. Why does the speaker think Canadian youth have more addictive behaviors than American children? This is something that came up in your talk, and they were just wondering about some insights along that.
I'm sorry, I missed the question there.
Why does the speaker think Canadian youth have more addictive behavior than US children?
Why do we have more addictive behaviors?
Yes.
So I didn't actually provide the data in terms of the graph itself, but we've actually at the group in Waterloo, they've been tracking vaping rates, and our rates of vaping nicotine have actually surpassed that of the US. This was actually recently reported on the national last week. So this is Dr. Hammond's group in Waterloo. So it's actually the data that's been just recently captured.
Oh, okay.
So specifically to vaping, just to make sure that's clear, it's specifically related to vaping.
There is another question from Fazal. They're asking, I think, one about one of your cases that you had mentioned. They asked, was Tyler taking ADHD medications?
Was Tyler taking ADHD medications?
Yeah.
So these were actual cases, but in fact, he was not. And it's a great question in terms of the risk around substance use, abusing stimulant use in this case. Yeah.
Another question comes from Patricia Rodriguez. What do you recommend if parents don't know about their children's substance use?
That's a great question. And in fact, actually, the data suggests that it's the parents that tend to be the ones that initiate treatment because when they do actually have a suspicion. So I would honestly, at this point, I think to support kind of acquiring the quickest care if needed and thinking about prevention, it's a dialogue. It's knowing what your adolescents are doing. If you have an adolescent, it's just being aware of who their friends are. I'd probably say friends are probably one of the most important aspects here, especially as they approach middle adolescence. So yeah, it is a dialogue.
Great. So thank you very much, Trish. I think that's all the questions we have tonight. Big round of applause. You did a great job in finishing up our conference today. It was a great, to be honest, I think all of us can actually reflect on this and say, this is amazing success. We had over 250 registered participants at our peak participation. I think we're about at 150 during any one time. And I think I consistently saw it over 110 and 130 throughout most of the evening. So really a big round of applause for everybody who organized this, who participated, who spoke at our conference. I'm now gonna invite Dr. Hamid, our director for the Paediatric Pearls, to close up with his remarks.
Thank you. Yes, you're right. I must say that our participants were quite enthusiastically listening our presenters, amazing presenters talk, and you rightly said that this overall conference, the background of the technology would not be easy for us to manage if we had not had these two wonderful volunteers for us helping alongside. Last, I would say, and thank you all of our presenters, especially Hamid Marshan, who took some time from UK to join and deliver a wonderful talk. And yes, at the last, I could say is thank you, Hubert, for being a very wonderful moderator. You have done the great job you become a whip to all our presenters. You're keeping the time so we can finish on time. It's 8:20. So we are only a few minutes, perhaps we are a few minutes early. And I would request all of the participants to fill the CME. It not only give you the CME certificates, but it will give us some food for thought in terms of shaping up or organizing our next year conference. Thank you.
Thank you, Hamid. Thank you, everybody. Thank you, Lakshmin. Thank you, everybody who has really kind of participated, and for all the speakers as well. Take care.